Hello everyone. We'll be waiting for another 2-3 minutes. Let people are still joining, and we'll as soon as there is a quota, we can start. Okay, Dr. Harare, you are ready? I will
Yes,
share the screen.
yeah, I will share it from my side. Yeah.
Yes, you can try. Yes, sir. We can see.
Yes. Okay.
Good.
Hmm.
Yes, sir.
Mhm.
आपले instructions आणि हे होईपर्यंत
Hello everyone. Good evening and welcome for this webinar on diabetes and cardiorenal complications. We'll start with the introduction. So by the time the people will join. Yes. Good evening and welcome to this webinar on diabetes and cardiorenal complications. So here we are having experts from all the this thing from cardiology, then nephrology and diabetologists. So we'll be today discussing about the cardiorenal complications, as well as we'll be discussing the management also. So please be there, because it's a very interesting topics are there, like treatment intensification with SGLT2 inhibitors and DPP4 inhibitors. Then again, preventive and managing cardiorenal risk of diabetic dyslipidemia. So very interesting topics are there. So I just narrated you two. There are 6 topics. So it will be half an hour each, and then we'll start with this. So I will now tell my our president, IMA Pune, Dr. Meenakshi Deshpande, to give her opening remarks.
Good evening, everybody. I hope everybody has joined in. I can see 30 people who have joined at present. Evening time, I think palkis have come. And so mostly everybody must be in the traffic, or they must be reaching to their clinics. So I hope everybody will keep on joining slowly and gradually as they come to know about it. By that time, we will start with the first lecture. And this is I think this is the 4th. We have started from March. So March, April, May, June. So this is the 4th module which we are taking from AstraZeneca. And this is a very good concept of having one afternoon webinar every month, and which gives us a clinical touch remains of all the doctors who are attending it. And this also has concerns with diabetes. So diabetes is the real killer of the society today. And really it is a comorbid condition which needs to be focused every now and then for the treatment modalities. And this is a very good work which AstraZeneca is doing with, of course, IMA Pune. And we would appreciate AstraZeneca for that. Second thing, I would like to brief all of you who have joined for some few programs which we are having in the pipeline. I would request everybody of you, the faculties, whoever is listening as delegates, to keep themselves free on 10th of July. We are having a blood donation program in association with Janakalyan Blood Bank. and all the healthy and the wealthy people, I mean, who are having lots of blood. So come up and do the blood donations, and also encourage your friends, your relatives, and your colleagues to come to IMA Pune premises on 10th of July, Sunday morning at 9 o'clock for blood donation. And also we'll be having a CME along with it on blood products and hematology CME, hematology CME by Janakalyan Blood Bank itself. So Dr. Atul Kulkarni is arranging, he is the convener. And so we are requesting wholeheartedly to participate in the blood donation as well as in the CME. The second next best program which we are having in the future is of UConn, is the IMA Maharashtra State Women's Doctors Wing Conference, open for all gents doctors to participate also and to act also. So it's not only for women doctors, it's for gents. And I would request all of you to register for this very happening conference, which is hosted by IMA Pune on 27th and 28th August. And we are having it at a very elite ambience venue, which is a boat club, Royal Connaught Boat Club, from Saturday morning 9 o'clock. Various events have been planned for those 2 days also. And I think everybody of you will not only enjoy, they will relish them in the memories. So register for that. We are sending the messages to all over all the groups, on all the WhatsApp communication groups, and by emails also. So that's all for today from me, and we will go on with our talks. We are experts who are going to speak. So I would request our secretary, Dr. Alka Madam, to introduce.
Thank you, Madam. Today's the first lecture is by Dr. Vinayak Harade. It is on treatment intensification with SGL2 inhibitors and DPP4 inhibitors. So I will just introduce Dr. Vinayak Harade in short. He is a MBBS from IMUHS, MD General Medicine from Sion Hospital, Mumbai, and DNB from General Medicine National Board, New Delhi in 2012. And he is also a DNB person. He has done his DNB in endocrinology, diabetes, and metabolism from PD Hinduja National Hospital and Medical Research Center in 2016. He has been worked in PD Hinduja Hospital and Sion Hospital, that is LTMG Hospital, and he has got distinction, mainly to tell that he's got distinction. It's a very hard subject of pharmacology. In that subject, he has got a distinction, and he's a member of IMA, of course, and Indian Endocrinology Endodontic Society, India Society for Bones and Mineral Research, Endocrine Society USA, Growth Hormone Research Society, International Osteoporosis Foundation, Indian Thyroid Society. So over to Dr. Vinayak Harade. Welcome, sir, and you can start your talk, sir.
Thank you, ma'am, for your kind introduction. Thank you, team IMA Pune and AstraZeneca team for inviting me for the today's session. So I'll be talking on treatment intensification with SGLT2 inhibitor and DP4 inhibitor. So it's a very interesting topic because we all are using this combination of this SGLT2 inhibitor plus DP4 inhibitor, but I'll be talking about this combination of using dapagliflozin and the saxagliptin. There are lots of initially the thought about the saxagliptin, about the hospitalization for the heart failure. So how we can use saxagliptin with the dapagliflozin? What are the real evidences with the newer studies, newer meta-analysis, and what are the little pitfalls with the Savartimi 53 trial when the saxagliptin was initially studied? So all this we are going to discuss in today's session. So to start with, we all know that dapagliflozin inhibits the SGLT2 by an insulin-independent mechanism to remove the excess glucose in the urine, and that's why it has this insulin-independent action. That's why there will be lesser risk of any hypoglycemia. And dapagliflozin is more than 1400 times more selective for the SGLT2 versus SGLT1. So we all know this basic mechanism of action of the dapagliflozin, and we also know that when we add, there is a add-on therapy with the dapagliflozin, it results into the significant reduction in the HbA1c. So whether we can add with the metformin plus sulfonylurea, or we can even add with the exenatide, which is GLP-1 receptor agonist, when added to with the metformin, with sitagliptin and metformin, or even when it was added with the insulin with other any oral glucose lowering therapy. There is a significant further HbA1c reduction is observed whenever we add dapagliflozin with this other oral antidiabetic or GLP-1 or insulin. And also there is a significant weight reduction is also observed whenever we add dapagliflozin with the other oral antidiabetic like metformin, SU, GLP-1RA or other DPP-4 inhibitor, or even SGLT for that matter. And this weight reduction is also a BMI dependent. So the higher baseline BMI, the more weight reduction is observed with dapagliflozin. And there are multiple glycemic as well as extra glycemic benefits of the dapagliflozin. As if whenever we use dapagliflozin with the higher baseline HbA1c, we do get the better HbA1c reduction. Here you can see whenever there is a baseline HbA1c of almost 9.42%, the HbA1c reduction by the end of 24 weeks was around 1.3 to 1.4%. And also there are various extra glycemic benefit as well with the DAPA, like there is a reduction in the systolic as well as the diastolic blood pressure over the period of time with the use of the dapagliflozin. And this data is also sustainable for the period over the period of 4 years. So when it was compared with the agent like glipizide plus metformin, it clearly shown that at the 52 weeks there is a reduction in the HbA1c which was statistically non-inferior to the glipizide. And when it was further studied up to the 208 weeks, there is a reduction in the this reduction was sustained over the period of 4 years. And also the extra glycemic benefits like the blood pressure reduction, body weight reduction was also maintained over the period of 4 years. And obviously there would be a low risk of hypoglycemia if we compare with the sulfonylurea like glipizide. The dapagliflozin has a very low risk of hypoglycemia. Then what is the need for the treatment intensification when we are getting all this good reduction with only with the dapagliflozin? So why do we have the combination, or why should we combine dapagliflozin with any other molecule? So we all know that the global prevalence of the diabetes by IDF 2021, the world number of diabetic population in 2021 was 537 million, and it was projected to increase by 46% by 2045. And the number would be around 794 million people living with diabetes in 2045 year. And this increase was projected almost by 68% in the Southeast Asia. And also we have this real world evidence study by Dr. Sanjay Kalra et al, where they studied the Indian patient, and they have shown that the Indian patients are at HbA1c 8.6% even after 4.5 years of first line treatment. So this is really not good data to find out that in this Discover trial, almost after 4 years after starting the treatment, the average HbA1c of the most of this diabetic patient is around 8.6%. And similar studies were also conducted in the various zones of the India, where they found that the average HbA1c of the Indian diabetic patient, even after starting the treatment after 4 to 5 years, it is around 9%. So we are not getting the good HbA1c control. So that's why it's a need of our to start the combination therapy at the very early stage of the treatment. So what do we need to do in the type 2 diabetes management? So we should have a good glycemic control, try to achieve the patient's fasting plasma glucose below 130, PP below 180, and HbA1c below 7%. Weight management is also important. We should have a molecule which will not only help for the glucose control, but also there would be additional weight reduction benefit, and definitely there would be no weight gain. And also there should be additional benefits like we should manage the patient's hypertension, dyslipidemia, and we should also ensure the safety, which includes a low risk of hypoglycemia. So we should have such molecule which fits on all these parameters, and so that's why we have this rationale for this DAPA-SEXA combination. So why do we select this combination DAPA-SEXA, which is a SGLT2 inhibitor plus DPP-4 inhibitor combination? We all know that this omnious octet, which results into the hyperglycemia, it's pathophysiological defects in type 2 diabetes. And when we give this DAPA-SEXA combination, it shall cover the 6 out of 8 these mechanisms when it is given with the metformin. So most of these defects are controlled or taken care by this combination of DAPA-SEXA along with the metformin. And also why again this DAPA-SEXA combination as against the other agents, other oral antidiabetic agents like metformin, sulfonyl, or TZD. So if you see, the hypoglycemia risk is very low with both this combination, DAPA and dapagliflozin and sexagliptin. If you see the effect on the weight, DP4 inhibitor, they are the weight neutral, whereas the SGLT2 inhibitor like dapagliflozin can cause the weight loss. CV safety is there in the both these molecules, DP4 inhibitor as well as the SGLT2 inhibitor. And also there is a systolic blood pressure reduction with the SGLT2 inhibitor, whereas it is neutral with DP4 inhibitor. If you see the TZD, that is thiazolidinedione, there is a weight gain issue is there with thiazolidinedione. And also the sulfonylurea, again, the major concern is the risk of hypoglycemia is there and the weight gain. So all these risk factors are there with this. But metformin is very much neutral, so it can be definitely combined with the DP4 inhibitor and SGLT2 inhibitor to achieve the 6 out of 8 pathophysiological defects. In DECLARE-TIMI 58 trial, the primary endpoint of this DECLARE-TIMI 58, we have seen that the composite of the hospitalization for the heart failure or the cardiovascular death, there was 17% relative risk reduction with the dapagliflozin 10 mg when it was compared with the placebo. And also interestingly to know that in DECLARE-TIMI 58 trial, when the dapagliflozin, it slowed the renal disease progression in type 2 diabetes patient with relatively good baseline renal function. So on the left side, if you see the comparison between DECLARE, CANVAS, and EMPIRIC outcome trial, the mean EGFR was in DECLARE-TIMI 58, it was 85, whereas it in CANVAS or EMPIRIC, it was lower side, that around 74, 76. And macroalbuminuria percentage was also 30%. Urinary microalbumin, microalbumin creatinine ratio, it was 30. So again, so it basically shows that what are the most of the patient what we treat in our day-to-day clinical practices, again more relevant goes with the DECLARE-TIMI 50 trial as against the CANVAS or EMPIRIC outcome trial. So it translates into our day-to-day clinical practice. So most of the patient, they are not very with the low EGFR or very deranged microalbuminuria. So that's why it's more relevant in our day-to-day clinical practice. Also in DECLARE, it confirmed the safety profile of the dapagliflozin when it was there is extensively, it was studied in more than 17,000 patients over the period of 4 years. It clearly showed that there was no any significant increase in the major adverse event as against the placebo. And dapagliflozin is backed with the wealth of experience as well, with over 2.5 million patients treated across more than 90 countries. In DAPA-HF trial, which is the first and largest SGLT2 inhibitor heart failure with reduced ejection fraction trial to successfully improve the outcomes and symptoms. So in DAPA-HF, the more than 4,700 odd patients were there when there was 1:1 double blind was done with DAPA 10 mg versus placebo. And interestingly, if you see, there were type diabetes as well as non-diabetic patients were there. So type 2 diabetes were 45% and 55% were not having diabetes. So this is very important thing in DAPA-HF. So it was studied in normal and non-diabetic patient as well. And there is a significant reduction in the composite of CV death or worsening of the heart failure, which results into the 26% relative risk reduction with the dapagliflozin. And if you see the number needed to treat it, just 21 with dapagliflozin. Also, there is a CV death reduction by 18% reduction is there, and hospitalization for the heart failure is also 30% relative risk reduction is there. And this consistent benefit is seen across a broad and representative population, whether patient have baseline diabetes or not, or whatever the baseline LVEF, background heart failure therapy, baseline NT-proBNP value, whether patient is on diuretic usage or not, and irrespective of their dosages, EGFR. So in all these various subgroup analysis, the benefit was seen with the dapagliflozin. There is a reduction in the risk of both first as well as the recurrent hospitalization for the heart failure events, reduction in the all-cause mortality, and heart failure symptom improvement was clearly seen with the dapagliflozin. when it was studied with various questionnaires whether their quality of life is improved with the DAPA or not, and significantly reduce the risk of CV death or worsening of the heart failure as early as just day 28. So this graph was separating with the placebo. It was very early at just day 28. So by the end of 1 month, the benefit was seen with the dapagliflozin. Whereas the DAPA-HF safety, DAPA was very well tolerated in patients with or without type 2 diabetes, and adverse event rarely led to the discontinuation of the treatment, and no events of major hypoglycemia or decay in patients without type 2 diabetes. Again, one of the interesting finding in this study, it was that when it was used in non-diabetic patient, there was again it reduces the development of the future diabetes in those patients. So again, this was one of the interesting finding in DAPA-HF when it was used in the non-diabetic patients. DAPA also significantly reduced the primary endpoint regardless of the diabetes status and HbA1c in the number of type 2 diabetes groups. So whether there is a normoglycemia with the HbA1c when it is less than 5.7% pre-diabetes patient with HbA1c 5.7 to 6.5, or in type 2 diabetic population. So in all these groups, there is a significant all these benefits of the dapagliflozin for the cardiovascular death reduction or the hospitalization for the heart failure or urgent heart failure visit. So all these when the events were reduced with the DAPA 10 mg. Will a combination of the DAPA-SEXA addresses the dual concern of the glycemic control as well as the cardiorenal risk reduction? We'll try to see this DAPA-SEXA combination. And so there is a reduction in the HbA1c were greater with the DAPA-SEXA combination across all the baseline HbA1c subgroups. So here there are three groups. You can see less than 8% baseline HbA1c, 8 to 9%, and more than 9% baseline HbA1c. So whenever we use in the combination of the DAPA-SEXA along with metformin, there is a significant more A1c reduction when it was compared with the individual use of the sexagliptin plus metformin and DAPA plus metformin. So this benefit is across the various so this benefit was seen across all this baseline HbA1c population when we use the combination of the DAPA and sexagliptin. Okay. Glycemic efficacy of DP4 inhibitor in this meta-analysis of the 58 RCTs and more than 30,000 odd patients, when it clearly shown that the sexagliptin has the most powerful reduction in the combination usages. When the sexagliptin, when it was compared with the other DP4 inhibitor like sitagliptin, vildagliptin, alogliptin, and linagliptin, it clearly showed that the sexagliptin has a better glycemic HbA1c reduction when it was compared with the dapagliflozin. DAPA-SEXA treatment also leads to the significant increase in the HDL cholesterol and significant reduction in the triglyceride rather than either used alone. So again, it's an interesting finding because there is a good amount of this lipid improvement is there with DAPA-SEXA combination as against the individual use of sexagliptin or dapagliflozin, reduction in the triglyceride level as well as the increase in the level of the HDL cholesterol. Sexagliptin also shown to reduce the or reverses the microalbuminuria to normal levels in more than 31% in this particular study by Dr. Jacob et al. When sexagliptin was studied in diabetic patients and the renal impairment, it clearly shown that there is a significant reduction in the microalbuminuria to the normal area. DAPA-SEXA fixed dose combination has a safety profile when it was compared with its mono components, sexagliptin and dapagliflozin, including to the low risk of hypoglycemia. Particularly, if you see the incidence of this genital infection and the volume depletion events were 50% lower when the combination of the sexa and dapagliflozin was used against the dapagliflozin alone. So if you see here, there is a 3% incidence of the genital infection with the sexa-dapa combination as against the dapagliflozin alone. It could cause almost 6% incidences of the genital infection. Finally, is there a concern with heart failure regarding the saxagliptin? Again, that is most the query by most of us, because initially when the saxagliptin was came out, there was lots of this concern with the for the saxagliptin in the severity 53. We have seen that there is an increase in the risk of hospitalization for the heart failure with saxagliptin. But the hazard ratio or hazard ratio of the hospitalization for the heart failure is reducing as we continue to expose the patients to the medication, and may have further reduced if the trial didn't end in 2 years. So the trial was ended in just 2 years, but if it was continued, if we can see there is a progressive reduction in the hazard ratio over the period of time with the saxagliptin. And these are the saxagliptin and the congestive heart failure based on the severity 50 trial. The rehospitalization after the initial heart failure hospitalization was similar between both the groups, whether it is a placebo or saxagliptin, and there was no difference in the weight overall or in those with the history of congestive heart failure. So weight was also same, and there is no clinically detectable fluid overload was there. No differences in the troponin or C-reactive protein between both the groups. Medication saxagliptin was continued in all the patients, and the hospitalization for the heart failure issue caused by 61 patients in the saxam could have been a play of chance due to randomization error. So these were the theories which shows that it could be it can be because of this randomization error, because only 61 patient in the saxagliptin arm could have had this issue of hospitalization for the heart failure. And as per this Korean real-world evidence data on the almost 5 lakh patient, when it was compared with the other difurin inhibitor, saxagliptin was associated with low risk of cardiovascular death. So in this real-world evidence of more than 5 lakh patients, you can see the sitagliptin versus the various other gliptin, the main analysis as well as the analysis of the health screening data. And it clearly showed that when it was studied again versus the other gliptins like vildagliptin, saxagliptin, linagliptin, or gliptin. So in this trial, saxagliptin was associated with the low risk of the cardiovascular disease. Also, the effect of the saxagliptin on the left ventricular structure and function in patients with the type 2 diabetes and heart failure, the results of the major HF trial. Based on the results of the SAVOR-TIMI 53, the saxagliptin has been suggested to increase the risk of hospitalization for the heart failure, whereas this is a chance finding or because of the patient selection in the SAVOR-TIMI 53 remains uncertain. But when another study was planned, this major HF trial, when it compared the effect of the saxagliptin with placebo when added to the standard care on left ventricular end diastolic volume index, which is LV-EDVI, when it was assessed by the MRI and other imaging and biomarkers of interest in patients with heart failure and type 2 diabetes. So in this trial, the difurin inhibitor sitagliptin was also added to the standard care, which has not been associated with an increased risk of HHF, was also included in another control group. So what are the results of this major HF trial? So this design of this trial, it is a 24-week multi-center randomized double-blind parallel group placebo control study, where they included the patients with the documented inclusion criteria was the documented controlled type 2 diabetic patient and heart failure demonstrated by 3 criteria with LVF less than 45%, elevated NT-proBNP more than 300 pg per ml, and optimized and stable standard treatment for heart failure with ejection fraction. Heart failure with reduced ejection fraction, and the patients with type 2 diabetes and heart failure, the sample size was 348 patients, and they were randomized with either saxagliptin 5 or 2.5 mg, sita 100 or 50 mg, and placebo. And the primary endpoint was the change from the baseline in the left ventricular end diastolic volume index measured by the MRI at 24 weeks. And whereas the various secondary endpoint was studied, like change from the baseline to week 24 measured by MRI left ventricular end systolic volume, left ventricular ejection fraction, left ventricular mass, and terminal prohormone or of brain NT-proBNP values. So the primary analysis, the left ventricular end diastolic volume, you can see there is no significant difference with saxagliptin when it was with the placebo. In fact, there is a reduction in this value of the LV-EDV. And also there is a secondary analysis The various parameters were studied with left ventricular end systolic volume, left ventricular ejection fraction, ventricular mass, NT-proBNP level. Again, there was no any significant increase in with the levels were seen with saxagliptin when it was compared with the placebo. These are the various CV events observed with the saxagliptin, sitagliptin, and placebo. So the number of the patients with any events of the heart failure, MI, stroke, or death, again, it was low with the saxagliptin as against the sita or placebo. Number of patients with any heart failure related event were 9 and 10 in sax and sitagliptin respectively. Number of patients with any MI also were almost comparable in the both the arms. The number of patients with any stroke or death or adjunct so all these events were relatively comparable with the sitagliptin, or the numbers were numerically less, even though it was statistically not significant. So all these findings clearly shown that saxagliptin plus standard care was non-inferior to the placebo and did not show any significant changes in the LVEDVI, which is left ventricular end diastolic volume, LVS, VI, LVEF, LVM, or NT-proBNP from baseline to 24 weeks compared with the placebo plus standard care in patients with type 2 diabetes and heart failure. The effect of saxagliptin on cardiac structural changes when also compared with the placebo plus standard care in patients with type 2 diabetes and heart failure were similar. The major HF trial did not demonstrate any cardiac structural or biomarker changes indicative of the worsening of the heart failure in patients with type 2 diabetes who had established symptomatic HF and were randomized to saxagliptin compared with the placebo added to the standard care. So all these evidence clearly show that there is no any major issue of hospitalization for the heart failure with the saxagliptin. And we all know that in this ACA consensus statement, the higher SGLT2 recommendation is there than ever before, and it's the first line recommendation in the selected group. So irrespective of the patient's glycemic control, so irrespective of the patient's baseline HbA1c, if there is an established ASCVD or high risk patients or CKD stage 3 or HFRA, we can directly start with either SGLT2 inhibitor or GLP-1RA with proven efficacy, and thus the SGLT2 inhibitor recommended independent of the, this glycemic control in high CV risk patient. Also, in the standard of medical care in diabetes, this recent ADA 2022 guidelines also enters the same thing, irrespective of the patient's baseline HbA1c, if the patient has ASCVD or indicators of the high risk or CKD patient. In all these patients, we have to use either SGLT2 inhibitor or GLP-1 receptor agonist. ADA guidelines also, there is a evidence with different SGLT2 inhibitors. So particularly with the dapagliflozin, you can see their primary heart failure outcome data is there, primary renal outcome data, and reduction in the heart failure and CKD progression in the CVOT. So all this data is there only with dapagliflozin when it is compared with CANA or empagliflozin. And because of all this data of dapagliflozin, European Journal of Heart Failure also there is also this position paper. It clearly mentioned that the dapagliflozin could be considered in the treatment of patients with the heart failure with reduced ejection fraction with and without type 2 diabetes. To summarize, SGLT2 inhibitor have a potential clinical benefit in glucose control by action independent of the insulin. In DECLARE, we have seen that the primary composite outcome of hospitalization for the heart failure or CV death was significantly reduced with the DAPA when it was compared with the placebo. Dapagliflozin appears to reduce the risk for the onset and progression of the renal dysfunction and kidney disease in type 2 diabetes. DAPA-HF is the first heart failure outcome trial with an SGLT2 inhibitor investigating the treatment of heart failure in adults with heart failure with reduced ejection fraction on top of standard care. And DAPA plus saxagliptin, which has a proven efficacy, good glycemic control, and safety profile comparable to its monocomponent, including the low risk of hypoglycemia. So thank you very much for your patient listening. I will stop here. If there are any questions, you can.
Sir, it was a very nice elaborative lecture.
Thank
Sir,
you.
there is one question. Means Dr. Amit Daira is asking question. So please, you can read the question.
Okay. Yes, I will read, ma'am. Do you evaluate a young 25 to 30 year with new onset diabetes who does not have obvious type 2 diabetic phenotype approach to it? Okay. So this question is a little different actually. 1 minute. Okay, so if the patient is there is no obvious phenotype of type 2 diabetes. If the younger patient, basically, the doctor wants to ask me, 25 to 30 year patient with a very high sugar at the first time without any phenotypic appearance of type 2 diabetes. Like phenotypic appearance means if there is insulin resistance, acanthosis nigricans, typical family history, obesity. So all these factors are not there. Then how we can evaluate for the other risk factors? So in the particularly in the patients with of the MOD, maturity onset of diabetes of the young. So in this patient, the family history is very important. So first generation or many relatives of the parents, siblings, or grandparents. So most of these 2 to 3 generation have the very young onset diabetes history is there, and if this significant family history is there, and this patient, they do not have the various severe osmotic symptom at the onset of diabetes presentation, and they also will not have the markers of the type 2 diabetes like acanthosis nigricans. So this will be also it will not be there, and these are little milder form of diabetes when they come MODY type of diabetes. And if this family history is significantly present is there, and so it's basically best to do the genetic analysis. So there are different types of the MODY diabetes, MODY1, and almost there are 16 different genetic types, out of which most common is type 2 and type 3. And if we do this genetic analysis, we can get the exact what type. And these patients are mostly responding to the oral anti-diabetic agents for the longer duration time. Whereas the LADA is latent autoimmune diabetes of adult. In this patient, they are mostly actually, this is question not relevant to our talk actually. So if it is a time, if you are consuming, then we can go to the next question.
Yes, sir. So the same person has asked question. Same doctor.
Okay, heart failure and sexagliptin. So the concerns we have clearly discussed in our this study. The various this Korean meta-analysis trial was there, where the more than 5 lakh patients were studied. It clearly shown that there was no increase in the risk of hospitalization for the heart failure with the saxagliptin. Also, the major HF trial also we have seen in the last, it clearly shown that there is also no increase in the risk of hospitalization for the heart failure with the saxagliptin, even when it was compared with the sitagliptin also in that another arm. And when this trial was actually, it was done for the longer duration, so we could have get the lesser hazard ratio with the saxagliptin. So all these points we already discussed in this session.
Yes, sir. Thank you.
Thank you, ma'am.
Thank you, sir. Now I request our President, Madam, Dr. Meenakshi Deshpande, Madam, to felicitate you. Dr.
Vinayak Harade, sir.
Yeah.
Yeah,
I
thank you.
welcome you to IMA Pune also
Yes.
whenever is possible.
Yeah.
And thank you for a very nice and interesting lecture.
Thank you, ma'am.
It's a bouquet for you and an IMA Uparana for you.
Thank you, ma'am.
Sir, and many of the, you must
And
be.
an IMA Uparana for you. I mean, we are offering it virtually because this is a virtual conference.
I'm also accepting virtual.
Yeah, we would like to give it to you
Yeah,
personally.
other speakers can come to IMA anytime.
Yes,
And
ma'am.
sir, many of the delegates, they have attended a 12 module diabetic course.
Oh, great.
Yeah, online certificate course from our IMA Pune. It has been just last on 19 June. There was a diabetic food workshop. So all the people who are attending now, we have given them the link. So they have joined. So they will be asking questions because their knowledge of diabetes is quite full.
Yes.
They are going to practice. So they have many queries. So
Yes.
sorry for that. So
No,
it's okay.
no, ma'am.
Thank you, sir. Thank you.
Thank you, ma'am.
Yes, sir. Yes, sir. Now the second lecture is preventing and managing cardiorenal risk of diabetic dyslipidemia. So Dr. Jaideep Rewale will be, sir. Welcome and good evening, sir.
Good evening. Am I audible?
Yes, sir. Yes, sir.
Yes,
Great.
sir.
You can share your screen and you can try. By the time I will introduce you. Sir is a MBBS fellowship in diabetology, gold medal. He is a chairman and consultant diabetologist. Dr. Rewale's Diabetes Nutrition Care and Research Center at Satara is a district's first center dedicated to diabetes care since 2008. He is a founder and director of DNA, that is Diabetes and Nutrition Awareness Academy. He is a co-founder of Premium Healthy Food Store. So he has, and he's an organizing secretary. He was rather for the 2018 conference at Mahabaleshwar. And his areas of interest are diabetes, food, and social awareness. And he has received Diabetes Awareness Initiative Award for 2016 from Maharashtra State at World Congress of Diabetes 2017. And he has delivered more than 400 lectures to various organizations. So what to sir? Sir, you can start.
Thank you, madam, for kind words and introduction. And at the outset, I would like to thank IMA Pune office bearers because they're actively involved into arranging such academic events. And I would like to express my gratitude to the AstraZeneca also for giving me this opportunity. And after the lucid presentation by Dr. Vinayak, my job is actually very easy. So I will take you through the prevention and the managing cardiorenal metabolic risk. So this is a sample patient. He's a newly diagnosed type 2 diabetic patient with the HbA1c of 8.4, BMI 24, blood pressure is fairly well controlled. His lipid parameters are LDL is on the higher side, EGFR is well maintained, but ACR values are more than 30, that is 50. So with this classical presentation, now patient is on the metformin 1000 milligram and dapagliflozin as a fixed dose combination. It was prescribed to this patient. Now let's go to some theory that type 2 diabetes is a chronic progressive disorder and the burden of cardiometabolic disease and dyslipidemia is very common in type 2 diabetic patients. Now let's look at some data that heart failure, CKD, and type 2 diabetes. So this is the data that globally 64 million patients are having heart failure. More than 843 million people are suffering from the CKD, and 24% patients of the type 2 diabetes have the heart failure as a first presentation or the first complication. And global prevalence, Dr. Vinayak has already explained about the global prevalence of the type 2 diabetes. So 58% patients with the type 2 diabetes will eventually develop chronic renal disease, and that is really a worried fact.
Please, sir, your slides are not visible. They are not moving forward, sir. Please.
They are not moving. Okay,
yeah.
okay. Let me check.
Again.
Also, please, sir, make it a full screen.
Yeah, it's a full screen. Now it's visible.
Yeah, now we can see, but as Dr. Mr. Dipen sir has told, you make it a full screen.
Yeah, already I have made a full screen. Okay. Now you are seeing this is the first patient slide. Is it?
Slides we can see, sir, but now you have to make it full screen.
I have made it a full screen, but unfortunately.
Okay.
Okay, let me share once again. Just give me.
You can guide. Depends, sir. You can guide him.
Yes.
Just
So click on the slideshow.
Just
There is a.
okay, give me just one minute.
Okay.
No. It's a screen.
Extremely sorry for this inconvenience. I think now it should. I hope it's moving now.
Yes.
Okay.
Now it's perfect.
I'm extremely sorry for this inconvenience.
Okay,
so we were here that the prevalence of diabetes and the prevalence of the chronic renal disease, and this is a scary statistic that 58% patients with the type 2 diabetes will ultimately end into the chronic renal failure. So now this is a cardiac function data that left ventricular dysfunction in asymptomatic type 2 diabetic patient. So if you look at this pie chart, almost 16% patient have the diastolic left ventricular dysfunction, 27% with the systolic, and 25% patient do have the systolic and diastolic as a combined. So overall, 68% patient who had a type 2 diabetes for a median 5 years showed the sign of left ventricular dysfunction in absence of indicible ischemia. So this is very, very important that to diagnose early and the management of asymptomatic left ventricular dysfunction and diabetic cardiomyopathy may be the future strategy to prevent the manifestations of the heart failure in these patients. So now we know that the CV risk associated with the diabetes and the high cholesterol. So there is a linear risk, CV risk, that is a higher 7-year incidence of the cardiovascular mortality in type 2 diabetes and the non-diabetic. On the left side chart, you can see that the patient who are not having diabetes and having diabetes, the risk of the cardiovascular disease is exponentially high. On the right side, we can see there is a direct correlation between the cardiovascular disease and cholesterol levels. So that is known fact, so there is nothing new in this. Now, while the glucose control is a fundamental in the management of the type 2 diabetes, we know that despite of controlling glucose HbA1c to the desirable level, we are not still able to prevent the macrovascular disease, that is a cardiovascular disease. Unfortunately, we are not able to prevent this. Most of the trials like UKPDS, ACCORD, ADVANCE, VADT has shown that the intensive glycemic control is able to prevent the microvascular disease, but there is still high risk of the macrovascular disease still keep on going. So there is a need of the molecule or the need of the therapy. We need not only think about the glycemic control, we have to go beyond this glucocentric approach and we have to manage patient as a whole. Now, coming to the CKD or the renal failure, diabetic nephropathy, we know that from the conventional treatment, if you go for the intensive treatment by providing the better HbA1c control, better lipid parameter control by addition of the AC meter for the blood pressure control, we can definitely reduce the incidence of the nephropathy maybe by 64%, but still there is 33 to 35% residual risk we are not able to address with the current available strategies of the intensification of the therapy. Now, what do we need to consider while treating the patients like Vinay? That we need to reduce the hyperglycemia, we need to prevent the cardiorenal complication, and of course, we need to manage their lipids very aggressively. Now, the glycemic efficacy of DAPA and unmet need. So now this is the same slide Dr. Vinayak has clearly explained that the add-on therapy with the dapagliflozin, if you add on to the metformin, you add with the sulfonylurea, or you add with the exenatide, we get the robust HbA1c reduction by almost 0.5 to 0.8% HbA1c reduction we could get with the addition of the dapagliflozin with any available oral hypoglycemic agent. Now, it's not only reduction in the HbA1c, but we need to address the obesity in our patients. So DAPA, along with the available oral hypoglycemic agent, the weight loss is significant, around 2.9 kg. If you give with the exenatide like molecule, we could get the weight loss of 3.5 kilogram in a patient. So this molecule not only gives the better HbA1c control, but this could address the obesity parameter also in our given patient. So now let's have a look at the prevention of the cardiorenal outcome. So we'll go through some trial data. We'll go fast. We'll talk about the prevention of the renal disease, prevention of the hospitalization for the heart failure and CV death. Dr. Vinayak has already explained most of these slides. So again, looking at the different trials like DECLARE, EMPOWER, CANVAS, and VERTIS CV, we can see that in DECLARE trial, almost 41 patients having the patients with the established ASCVD were enrolled, and the 59% patient had a increased risk for the ASCVD. So that was the basic difference between most of these trials. So when we think about the DECLARE trial, what it has showed that the DAPA slowed the renal disease progression in a patient with a type 2 diabetes, predominantly in a preserved renal function. This is very important to understand that whether patient is having preserved renal function or a patient is having micro or macroalbuminuria. In DECLARE-TIMI trial, it has shown that even with the preserved renal function, DAPA is able to slow the disease progression in terms of the renal disease. So this is very, very important in our patient. If the patient is having the preserved renal function, still DAPA will help to prevent renal parameters derangement in given patient. So there is 47% relative risk reduction in the progression of the renal disease. So now dapagliflozin has a favorable effect on the albuminuria across the baseline ACR categories, including patients with a normal albumin excretion. Now, if you see this slide, this very important slide, that on the first half of the slide, you can see that from the micro to normal albuminuria, again, it favors the DAPA. From macro to normal, macro or micro to normal, and macro or micro to normal. So whether patient is having normal albumin excretion, whether patient is having microalbuminuria or patient is having macroalbuminuria, in all subsets of the patient, dapagliflozin has a favorable effect in terms of the reduction in the albumin excretion. So this is very important to understand that all the spectrum from the normal albumin excretion to the macroalbuminuria, dapagliflozin does a wonderful job. Now, this is a broad CV risk population where the dapagliflozin has demonstrated significant reduction in the hospitalization for the heart failure and CV death, and fewer MACE events when it was compared with the placebo. So there is 17% relative risk reduction. It was statistically significant for the hospitalization for the heart failure or the CV death, and the MACE reduction was, though it doesn't reach to the statistical significant, but at least it was a non-inferior with the when it was compared with the placebo. Now, dapagliflozin has a well-established safety profile in a patient with the CKD and heart failure with reduced ejection fraction. So that, I think, Dr. Vinayak has clearly explained that slide, so we try to skip because it is the slide is not available in this slide set. So dapagliflozin in a treatment of the heart failure with the reduction ejection fraction and the CKD. So let's try to understand. This is the DAPA-HF trial. This is also Dr. Vinayak has clearly explained. So we'll just go very fast and we'll come to the, we'll focus only on a concluding point. So DAPA-HF trial was a very beautifully designed trial where it was the first and largest SGLT2 heart failure with the reduced ejection fraction trial to successfully improve the outcome and symptoms. So more than 4,700 patients were enrolled into this trial. Important to understand in this trial, why this trial was very, very important, because only 45% enrolled patient had type 2 diabetes. So 55% who were enrolled, so more than 2,400 patients who were enrolled into this trial were not having diabetes. So their non-diabetic population was also enrolled. It was 55%. So diabetes as well as non-diabetic population was enrolled with the reduced ejection fraction. And what was there was a significant reduction in the composite CV death and the worsening of the heart failure. There is 26% relative risk reduction, which is robust benefit patient could get. Now, what was the conclusion? So consistent benefit across the board and representative population, whether patient is having diabetes or patient is not having diabetes, patient on the background heart failure therapy, whether patient is having diuretic dose or baseline left ventricular ejection fraction, NT-proBNP levels and eGFR. Across all the ranges, all the patients got a fantastic benefit and it was statistically significant. DAPA was well tolerated in the patient with and without type 2 diabetes. So there was a significant reduction in the risk of both first and recurrent hospitalization for the heart failure event. There was a reduction in the all-cause mortality. Heart failure symptoms were improved, and this improvement was statistically significant, and there was a less common deterioration in the symptom score was seen. So, and this is another important fact, that the significant risk reduction was seen as early as on the day 28 of the starting of the therapy. So that is something wonderful. You start the patient on the dapagliflozin, and on the 28th day, majority of the patient will show the improvement. So that is something miraculous, I would say. So too early symptom relief. Now coming to the DAPA CKD, again, this is a very busy slide. So let's try to understand what it means. So DAPA CKD trial enrolled more than 4,300 patients, and the inclusion criteria was an eGFR between 25 to 75 and ACR. So look at the ACR values between 200 to 5,000. So all these patients have established nephropathy. Now, primary endpoint, there was 39% risk reduction in a composite sustained more than 50% eGFR decline. So 39% relative risk reduction, and number needed to treat was only 90. So that is again fantastic. And in this trial also, you can see on the pie chart, there are 32% patients were non-diabetic. So even in a non-diabetic with the nephropathy patient, this molecule gives excellent renal protection and the mitral reduction. So there was a 31% relative risk reduction in the all-cause mortality, 44% risk reduction in a composite outcome of a sustained GFR more than 50%, and there is 29% relative risk reduction in the CV death or the hospitalization for the heart failure. Now, from the safety point of view, DAPA was well tolerated in the patient with or without type 2 diabetes, and that's how it established its safety. Adverse event rarely lead to the discontinuation of the therapy. There was no major event like hypoglycemia, even in a patient with a type 2 diabetes, without type 2 diabetes. So non-diabetic patient also tolerated this drug very well, and there were no events of a decay with the DAPA. Now, what was the impact of this trial? The trial was stopped early due to overwhelming efficacy. So because the graph started separating too early and the primary endpoints was seen too early, that's why the trial was stopped too early to give this benefit to the patient. The first renal outcome study to show the robust benefits on all-cause mortality. So DAPA-CKD has its clinical importance because this is the first trial which has shown that there is clinically meaningful all-cause mortality reduction in a patient with or without type 2 diabetes. Now, hospitalization for the heart failure and CV death benefit has already seen, and with the declared demonstration, the cardiorenal protection across the spectrum of the diabetic kidney disease severity. So you take from the normal albumin excretion to the macral. So in any spectrum of the disease, dapagliflozin does a wonderful job. Now, we can clearly say that we can conclude with the dapagliflozin that it covers the entire spectrum of the cardiorenal continuum. So you take the declared trial, DAPA-HF and DAPA-CKD. We have seen all the three trials and the results. So DAPA does a wonderful job across the all cardiorenal continuum. Now, coming to the guidelines, this is again busy slide. Dr. Vinayak has clearly highlighted these guidelines. So what guidelines say is ADA 2022 that the patients with the high risk or the ASCVD, the GLP-1 RA or the SGLT2 inhibitor with the proven CV benefit should be prescribed. Patient with the heart failure, definitely SGLT2 is a choice with the proven benefit. Patients with the CKD and albuminuria and the CKD without albuminuria, preferably SGLT2 inhibitors with the primary evidence of the reduction in the CKD progression should be prescribed. So if you go through the guidelines also, the dapagliflozin really fits into the these particular criteria. So it is a SGLT2 recommendation has come very early when there is a ASCVD or the risk for the ASCVD, heart failure, or the patient with the established established CKD or with the proteinuria. Now, again, this is an algorithm for the glycemic management that for the monotherapy, we can definitely start with the metformin, GLP-1 RA, SGLT2, depending upon the patient profile. On the dual therapy, when the HbA1c rise between the 7.5 to 9%, then we need to think of dual therapy as an add-on to the metformin. But again, in this busy slide, the point to understand that treatment should be very patient-centric and patient-specific. If you always go with the guideline, it's very difficult and it's very confusing. So we need to understand the cardiovascular risk of the patient. What are the risk factors? Is there any microalbuminuria? And if it is there, then we need to select the molecule accordingly. So with the high ASCVD score or microalbuminuria or the abnormal protein excretion, or even with the normal protein excretion with the high risk of the cardiovascular disease, SGLT2 inhibitor is on the top line. Now, coming to the second half of the talk, that how to manage the lipid. These are the classical stages of the endothelial dysfunction. On the left side, we have the healthy endothelium, and there is the subclinical endothelial damage, where the endothelial dysfunction actually starts, and we could not pick because there are no symptoms, because it is at the subclinical stage. Then there is atherosclerotic disease, where there is a stable plaque, then unstable plaque, and ultimately patient goes into the complication. Now, the window of opportunity to intervene is at this stage, where the level of risk factor goes high, where the endothelial dysfunction actually starts. And we know that the diabetes is a vascular disease. So every patient at the diagnosis should be considered having some form of the endothelial dysfunction. So at the diagnosis itself, we have the window of opportunity. So this is the typical guideline of the LDL targets, that the DM without target organ damage, duration more than 10 years. These are the high risk patient. LDL target is less than 70 milligram per deciliter, or 50% reduction in the existing LDL level. Moderate risk patient, LDL target is less than 100, and low risk patient LDL target is less than 116. For practical purpose, as an Indian phenotype, we could say that the LDL target less than 100 should be very appropriate for the Indian patients. Now, coming to the intensification of the statin therapy, the statins are recommended even in a type 1 diabetic patient who are at the high risk. In type 2 diabetic patient, we know that the statin therapy is again a part and parcel of the diabetes management. We can't skip statins in our prescription when we want to treat our patient as a holistic approach. Now, when coming to the treatment of this lipidemia, statin should be considered before the introduction of the combination therapy. So we need to increase the dose of particular statin before jumping into the combination therapy. So intensification is very, very important, rather than adding another drug for the LDL control. Now, these are the ACC guidelines which recommend the 50% LDL reduction for the optimal ASCVD score. So diabetes mellitus with the age of between the 40 to 75 years, moderate intensity statin therapy is advisable. There is a class 1 indication, and diabetes mellitus between 40 to 75, and risk assessment to consider the high intensity statin, that is a class 2 indication. So we need to stratify our patients' cardiometabolic risk, and depending upon that, we need to intensify statin treatment. We cannot give a blanket treatment like a 10 milligram or the 5 milligram. We have seen the prescriptions where it was advised to take a statin alternate day, and there was a fad, I think few years back, to take a statin once a week for the prevention. So there is no proven data to use such type of the statin. So whenever we write statin, the intensification is very, very important, and we need to stratify patient into the different risk categories. Now, what is the importance of the 1 millimole, that is 38 milligram per deciliter reduction of the LDL? So these are the benefits we could get by simply reducing our LDL by 38 milligram or the 1 millimole per liter. We could reduce the major coronary events by 24%, coronary revascularization risk by 24%, stroke incidences by 15%, any vascular death by 12%, any death by 9%, and effect on major vascular events by 21%. So this is the power of this 1 millimole per liter reduction in the LDL, or 38 milligram per deciliter reduction in the LDL could lead to the reduction of the major vascular events by averaging by 21%. So that is one of the best benefit that we could offer to our patients. Now, again, the reduction by the 50% of the existing LDL target, we could reduce the event rate by 57%. So it's very interesting equation. You reduce the LDL, existing LDL by 50%, and the patient will get benefit of risk reduction by 57%. So this is Sonepe Suhaga. Now, again, coming to the which statin to choose, we know this is a Jupiter trial where rosuvastatin has shown that there was a 50% LDL reduction in a year, and there was a favorable effect on the HDL. There is 4% increase. So 50% LDL reduction with 17% TG reduction, HSCRP gone down by 37% to rosuvastatin. We know that this is from the Jupiter trial, and again, it has shown that the rosuvastatin treatment is able to reduce the risk of the CVD by 44%. And you can see the various these vascular parameters like myocardial infarction, stroke, death, revascularization, fatal, non-fatal stroke. You take any vascular parameter, and there is approximately 44% risk reduction with the rosuvastatin. Now, coming to the choosing the particular statin, what to choose? Because we have atorvastatin and rosuvastatin. Now, this is the Uranus trial where rosuvastatin was found to be more effective in a LDL-C reduction in the LDL plus HDL ratio and non-HDL when it was compared with the atorvastatin. And this data was also fairly old data, and this is now well established that rosuvastatin is superior than the atorvastatin. Now, coming to the how we can ensure the better efficacy and outcome. Now, coming to the innovator and some generic. So now generics in India are only proving bioequivalence to the innovators. So bioequivalence doesn't mean the therapeutic equivalence. So a mere bioequivalent generic may not necessarily lead to the same therapeutic effects as an innovator. And without an outcome-based clinical trial, equivalence cannot be established by the generic. So we know that there are some issues with the generic medicines, and somehow we could not get the same desirable effect, though the chemical structure might resemble. But when it comes to the clinical outcomes, the what we call it as a therapeutic equivalence, it doesn't actually translate into the therapeutic equivalence when we go for the generic drugs. Now, how the innovator molecule ensures the better efficacy and safety. So this is a very classical example that the presence of the methylated impurities in the generic. So methylated atorvastatin impurities was highly observed in the generic atorvastatin formulations. And these impurities was shown to have a no inhibitory effect on the HMG coenzyme. So this is very, very important, because if there is some chemical structure defect, then particular drug where it is going to act on the particular receptor, it might not act, and there is the issue of the bioavailability and their effect, adverse effect will start. The presence of such impurities in a widely available versions of the generic atorvastatin may compromise global efforts toward the effective management. Again, this is chemical structures, how the innovator molecule and the generic molecules, there are some chemical differences in terms of the some bonds, carbon moieties, and so we need not to go into the details. So now what we need to understand that the impurities can be formed during or after the production of the rosuvastatin tablets, and this can impact the stability of the rosuvastatin formulation over the shelf life. This is very important because when the drug is packed in the factory, and when patient opens the blister, the same chemical content and the properties of the drug should be maintained to get the desirable effect. Now, there comes the issue of the quality control and the biochemical structure of the particular drug, where the generic will be never able to match the innovator molecule. Now, what happened with the generic drugs when people start consuming generic drugs? This is the data which shows that the comparator to the innovator statins, the probability of suffering from the cardiovascular event with the generic was higher by 31%. So we need to understand that when our patient asks us, Dr. Saab, abhi main generic le lu kya? Dr. Saab, should I change my brand to some cheaper brand? We need to understand this, that maybe the cost effectiveness might lead to some hazardous effects. So in long run, actually patient is not saving money. In fact, he need to pay in terms of his health and in terms of some unwanted events also. So we need to understand that, and we need to try to convince our patient, at least for the drugs like which work on the vascular system, diabetes patients should not compromise on the innovator molecules, and they should not go for the generic drugs. Now, again, the same thing with the dapagliflozin, the having the right stereogenic center. So DAPA is having a chiral molecule with the 5 stereogenic centers. So these 5 stereogenic centers has been marked in red. So what is the importance of these centers? These centers are very important in terms of their bioavailability, rate of metabolism, metabolites, excretion, potency, selectivity for the particular receptor, transporter, and the enzyme, and ultimately the adverse events or the toxicity. So this is how the innovators are different from the generic. Now, I think a couple of slides and then I will stop. Can a cardiorenal benefits with the original DAPA can be extrapolated to the generic? Definitely not. So original dapagliflozin has an immediate onset of action. It is approved in the treatment of the CKD with or without type 2 diabetes with a 39% risk reduction. Reduction of all-cause mortality in a patient with a reduced ejection fraction with or without type 2 diabetes, 17% relative risk reduction, and reduction in the CV death by 18%. We don't have these type of robust data, clinical trial data with the EMPA. We don't have such robust data with the DAPA, and with the generic, there is no question of the data to get. So when it comes to my patient safety, I will always go with the evidence-based medicine. So where there is an evidence, I will try to prefer that particular drug or particular innovator molecule. So coming back to our patient who was prescribed metformin 1000 milligram along with the dapagliflozin, his HbA1c came down fantastic to 7%. BMI has gone down by almost 1.5 kg per meter square. Blood pressure was fairly well controlled. His LDL dropped down from 110 to 70. eGFR is maintained. And the last point, ACR values. A patient had ACR values of 200. Now it has dropped down to the normal level of 28. So this is a typical patient which we get in our OPD, and DAPA can do the miracles to this patient. So to summarize, DAPA reduces the hyperglycemia with the low risk of hypoglycemia. It has the ability to work at the all stages of the disease and can be combined with the other classes of the anti-hyperglycemic agents. DAPA reduces the weight, blood pressure. It has a favorable cardiorenal benefit. And coming to the dyslipidemia, rosuvastatin is superior in terms of the LDL-C reduction, thereby reducing myocardial infarction, stroke, and revascularization CV death. Compared to the innovator statin, the probability of all-cause death because of generic was higher, and on an average it was from 30 to 60%. So we need to choose the molecule very wisely because there are a young number of generic products are getting pushed into the market. So we need to address our patient risk with the particular drug and proper drug. With this, I thank you again, team IMA for Pune for giving me this opportunity, to all the audience for their patience listening, and AstraZeneca for wonderful opportunity and academic fees. Thank you very much.
Yes, sir. Thank you very much. There are two questions, but I think we can see at the end, because we are running short of time. It's 7:15 already. So
Yeah.
Our another speaker, Dr. Nitin Patki, he has joined. So
I think we'll try to take the questions
short
at the end. Is it a good idea to take the questions at the end so that the
yes,
time?
so it will not disrupt our continuity. Okay.
Okay. So should I try to answer these questions very fast?
Yes, you can.
Okay, I will take just 2 to 3 minutes. So how do you evaluate the young patient? Okay, that has already. I visit a urology hospital regularly. Diabetic patient who develop the UTI, nosocomial, what should be done with the HLT2? Should it be stopped? Okay, I think these patients, when patient is having urinary symptoms like a UTI or nosocomial infection, the HLT2 inhibitor should be stopped for at least time being till the UTI gets clear. So that is very, very clear message. And should HLT2 inhibitor should be stopped few days prior to surgery in a view of ketoacidosis, or can be continued till the admission? I think better to stop if there is it is an elective surgery. It is always better to stop HLT2 inhibitors because there will be fluid imbalance. So that is a routine practice to stop HLT2 inhibitors prior to the surgery to avoid the risk of the ketosis. Patient will not go into the acidosis, but ketosis or the ketone production, because patient will be NBM post-surgery for maybe 6 hours, 12 hours, and the fluid management. So HLT2 preferably should be stopped on a safer ground. So I think I have answered both the questions.
Yes, thank you, sir. Thank you very much.
Thank you.
Now I request our President, Dr. Meenakshi Deshpande, Madam, to felicitate you.
Thank you, Dr. Jaideep.
Thank you, Madam.
That was a wonderful lecture, and I think in the prime time of your OPD, you are taking this lecture. So thanks a lot for you. And I wish to felicitate you with a bouquet and Uparna. You can come down to IMA Pune anytime. We will felicitate you personally.
Thank you, ma'am. It
So,
was pleasure being with the IMA Pune, and it's a very strong academic body and continuously active body. So it's pleasure to be part of this academic endeavor. And I congratulate both of you for taking these efforts.
thank you,
Thank
sir.
you,
Thank
sir.
you. Thank you.
Thank you. Thank you. Thank you.
We can
Okay, to the
go
next,
to the next lecture, sir. Dr.
Dr.
Nitin
Nitin
Patki,
Patki.
sir.
Has he joined?
Yes, sir. He has joined. Dr. Nitin Patki, sir.
Are you there, Dr. Nitin Patki?
Yes, yes, he's there.
Yes, yes, I'm here.
Yes,
Sir,
sir.
sir, your topic is keeping the flow going in an acute coronary syndrome patients heart with statins. So it's a very good topic for our listeners because they are all learning.
Yes,
So
madam. Thank
very
you very
nice
much.
and it's a,
Shall I
yes, sir.
share my
And
screen now?
I'll just introduce you, sir. Yes, sir. I will introduce you to the delegates and the rest of the speakers. Sir is having more than 35 years of clinical experience in the field of cardiology. He's a and currently he is associated with Doshi Hospital, Shivaji Nagar, NS Wadia Institute of Cardiology, and Jupiter Hospital, Baner, Pune, as leading cardiologist. Sir has done DM cardiology from Dr. Sampurnananda Medical College, Jodhpur in 1990. And he has published various research papers in leading international and national journals. And he has participated in various national and international conferences and CMEs as a speaker. So, over to sir. Sir, welcome and good evening.
Thank
You
you very
can
much.
start sharing your screen.
Yeah, madam, I'll just go off the video because it looks like the signals are dropping. So I'll just stay on the speaker and I
Okay,
will share the screen now.
Okay. Okay, sir. So you can start.
Okay, my screen is visible to you.
Yes, sir.
Yes, we can see now.
Shall I proceed?
Yes, sir.
Okay.
You can.
Thank you very much, IMA and AstraZeneca. Dr. Jaideep had a wonderful talk considering the treatment in diabetic patients. So I come in at a little later stage with patients who has acute coronary syndrome and what is the role of statins in the treatment of acute coronary syndrome. So to begin with a simple case, generally discussing a case takes the things a little easier and understanding is a little better. So this is a 37-year-old chap who has diabetes, hypertension. He's a smoker. He has dyslipidemia. All the risk factors are there, and he was on apparently proper treatment. He has blood pressure recorded, but not on the treatment for that. He has been on treatment for blood pressure with 20 milligrams of telmisartan, amlodipine. He listened to Dr. Jaideep and physician put him on the empagliflozin 10 milligrams. However, the treatment with statins is just rosuvastatin 5 milligrams when we are considering the LDL level of 168. So that is probably inadequate. Now, this patient has come with chest pain and the ECG showed some inferior acidity changes. Now, this patient, although he may have initially stable picture, that means no definite picture of ST elevation myocardial infarction, this patient will definitely be observed since he is having ongoing discomfort. And then we'll be looking for some clinical signs which will suggest that he is going into some acute coronary syndrome. So what we'll look for whether there's blood pressure dropping down or he's getting hypertension, whether he's getting any bradycardias or tachycardias or ventricular ectopics, whether he's developing any signs of ventricular failure and other things. So basically we need to recheck. The point to remember is that even though the initial ECG may not be remarkable, In such patients where there are significant risk factors and patient has ongoing symptoms, we should be checking their ECG repeatedly, maybe after an hour or so, and see if the patient has developed any ECG changes. So this patient, let us assume that he has confirmed acute coronary syndrome, STEMI or ST elevation myocardial infarction. So what will be the treatment? Obviously, he goes for angiography with plan to stent the culprit coronary artery. So in this patient, it was a left antidescending artery which was 100% occluded. One point to be remembered is he also has an additional block in one of his other arteries. We presume that it is a significant sized artery and there is a significant block in this other artery. Now remember that he underwent PTC only to left antidescending coronary artery, which was the culprit artery. The point to be made here is that in patients with acute myocardial infarction, ST elevation myocardial infarctions, it is generally only the culprit artery which we will address unless patient is in shock and shock is not getting recovered even after implanting the stent or re-establishing the flow in the culprit artery. So always and always remember that it's only the culprit artery to be addressed to unless there is a strong indication for additional artery to be treated. Many times we cardiologists feel that the other artery looks simple and we can address that quickly, but it doesn't so happen. Many times they land up with problems if we want to go for additional arteries. So that's a standard recommendation not to address those things. So in the immediate intervention, what we generally will do is we'll start on nitrates to relieve the pain. Beta blockers will be there depending on his clinical scenario. So make sure that he does not have any blocks, conduction blocks, that is first degree AV block or complete heart block. He does not have any hypotension or bradycardia. So these patients can receive beta blockers. He also obviously has to get dual antiplatelet therapy. We'll always load the antiplatelet therapy. So PDP receptor blockers most commonly used in this situation will be ticagrelor or aspirin will also be there. She would receive some form of anticoagulation, that is either heparin or low heparin, and he receives high dose statin therapy. Now this is a management in acute setting, whether he receives all the medicines, goes for angiography and the culprit artery is treated with angioplasty and the blood flow is re-established. In the long term, he will need the other general supportive cares, but the medicines which should be included in his discharge medication should be beta blockers, dual antiplatelet therapy, or what we call as DAPT. Whatever antihypertensives required will be there, and high dose statin therapy. Now, many times patients who have acute myocardial infarctions, at the time of discharge, they will generally be normotensive or hypotensive, and the blood pressure gradually comes up. So many times you may find that these patients were taken off antihypertensive therapy and asked to follow the blood pressure. The reason is we need to maintain a certain blood pressure to have the coronary flowing. If the patient has acute anterior myocardial infarction and his BP is say 90 systolic, then obviously the coronary perfusion will suffer, and we would not like to have that pressure when the patient has a stent in an acute coronary syndrome setting. So what is most important to be talked about today for this particular event is that we need to have their lipids managed properly to have a better long-term event-free survival. So what do we mean by management of these lipids properly? So patients who come with acute coronary syndrome, it is generally related to plaque rupture. So the lesions which are not basically very tight, so lesions something which are 50%, 60%, 70%, they will land up with plaque erosion or plaque rupture and cause acute coronary syndrome because of development of thrombus on this plaque rupture. So remember that it is not a very tight lesion which has progressed, will cause an acute ST elevation myocardial infarction. It is generally a moderate lesion which causes plaque rupture and then acute coronary syndrome. Important point to remember here is that many times it is more than one plaque which rupture at the same time in that particular patient. So although on angiography you will see one particular plaque which has ruptured and caused occlusion, on angiography it may not be seen, but there will be more than one plaques which have ruptured. Importance, these other vulnerable plaques or plaques ready to rupture or have already ruptured are the ones which are going to cause a subsequent event. So the subsequent events will not come not from this plaque which we have treated, but from the other plaques which have ruptured or are ready to rupture. So these are the plaques also which need to be taken care of when we want to treat this patient properly with for acute coronary syndrome. And what is important is that the higher LDL-C reduction which happens, the better will be the chances of reduction of MACCE, that is major adverse cardiovascular events. So if you want to reduce this major cardiovascular events, then you need to reduce that LDL cholesterol level significantly. And this particular slide says that you have to treat them with LDL-C level less than 70%. So if you reach LDL-C level less than 70%, the reduction in the events which you will get is to about 15%. But if you don't reach that, the reduction will be 27%. So if you are more aggressive in reducing LDL cholesterol to less than 70%, you will get that additional 12% benefits. What are the guideline recommendations for the management? Over the years, actually the statins were available since 1980s, and then we started having this various ATP guidelines. So ATP guidelines were there, then SSC AHA guidelines were there, ESC guidelines were there. So what you can see from this slide is that the goal of this LDL cholesterol in order to prevent the yes.
एक्सक्यूज मी सर सर तुम्ही जरा जवळ घेऊन बोला ना, तुमचा आवाज ना असं मध्ये फाटतोय, म्हणजे वी कांट हिअर यू प्रॉपरली.
Can you hear me now?
नाउ सर इट्स ओके. Yes.
Yeah. So what we can see from this slide is that the guidelines have evolved, and every time what has happened is that they are actually in lowering the level of LDL cholesterol, which should now from 130 of LDL cholesterol, now we have come down to almost 50 or 55. So this all has evolved over a period of time, because the benefits were seen, one, and secondly, the levels what were mentioned could be reached by the various medications available. So initially we didn't have statins as such to reduce LDL cholesterol that much. Then we had statins, but we are not potent. And now we have more potent statins and more additional therapies which can take the LDL cholesterol down to levels of less than 50. And the trials which conducted and brought the LDL cholesterol down to less than 50 actually showed significant reduction in mortality. So that's why the guidelines have now shifted over, and this new era suggests that in very high risk patients, we have the LDL cholesterol reduction should be more than 50%, that's for sure. But we need to go down even further to less than 55. So that means if the patient's initial LDL cholesterol was 130, 50% reduction will take you down to 70 or 65. But if you come down to less than 55 in a very high risk patient, then you are going to get additional benefits. The moral is that, moral of the story is that the lower you go, there is no lower limit below which the reduction in LDL cholesterol will not produce further beneficial effect. So if you can reduce LDL cholesterol safely without causing significant side effects, the lower the LDL level, you will definitely get more benefits. So what decides the level at which you need to go? We need to define the high risk, very high risk, or highest risk patient. And all these criteria have changed or evolved over a period of time. Initially, the ATP1 said coronary artery disease or two other risk factors. But as we go along, and the new guidelines will suggest that we'll score this and then decide whether the patient is in the low risk or moderate risk or high risk or very high risk. So there are, you can have this data copied, but it's available on the internet. See, here you decide the things which will take you down to the highest risk. So what will be the highest risk or very high risk? A patient who has already established atherosclerotic cardiovascular disease or a score. Now, score is a scoring system depending on various risk factors like diabetes, blood pressure, smoking, lipid profile, and that will tell you what is the risk of developing atherosclerotic cardiovascular disease in next 10-year period. And if this risk is more than 10%, then you are going to be in very high risk. If you have diabetes mellitus, Dr. Jagdeep was talking about, so diabetes with target organ damage or diabetes more than 10 years and already established atherosclerotic cardiovascular disease, then these are the very high risk patient, and the target suggested for this patient is LDL cholesterol of less than 55. So you can start with the lower LDL targets for a very low risk patient who are young patients who do not have any risk factors, who do not have significant family history. Then you can have target of LDL of around 110 to 120. But as you go higher in the risk, once you start developing more and more risk factors, which could be like diabetes, family history, smoking, dyslipidemia, family relatives, close family relatives having ischemic heart disease, the risk increases. And if you have established atherosclerotic cardiovascular disease, then the risk is highest. Now, what do I mean by established atherosclerotic cardiovascular disease? So either you have admission for established or diagnosed black and white diagnosis of ST elevation myocardial infarction, or coronary angiography showing at least 70% block in one of the coronary arteries, somebody who has undergone angioplasty or bypass surgery, or somebody who has imaging. Now, what do I mean by imaging? Imaging is not only coronary angiography, catheter angiography, but imaging by CT coronary angiography showing significant atherosclerotic vascular disease is also taken as established atherosclerotic cardiovascular disease. Mind you, this also involves vascular disease in other systems like carotid and peripheral artery disease. So these are the two important things which we generally tend to forget. Now, even cerebrovascular disease is sometimes noted because the patient has a stroke or CVA. Sometimes incidentally you do a carotid Doppler. But what we generally miss and we don't examine the patient properly for that is established peripheral vascular disease. So unless patient complains of claudications on exertion, we don't really look for. What it is, it does not mean is that you should do a peripheral Doppler in every patient and check for the established peripheral vascular disease. But a patient who comes to you for clinical evaluation, just check his peripheral pulses and then probe into his history of peripheral vascular disease. What will patient do is that if he starts getting symptoms on walking, he will just reduce the walking distance. And then he will say he doesn't have any trouble. But if you probe, then he will say he cannot walk because he gets pain in the legs. So remember, so atherosclerotic cardiovascular disease is not only coronary, it is carotid and peripheral also. And you have various modalities like coronary angiography, angioplasty, bypass surgery, CT coronary angiography, carotid Doppler or peripheral arterial Doppler to establish this atherosclerotic cardiovascular disease. So this, once you show that he has atherosclerotic cardiovascular disease, that means he is in a very high risk and he has target of LDL of 55. So optimal reduction in LDL levels should be at least 50% or more. That is what is recommended for any patient who has come with established atherosclerotic cardiovascular disease. Now the target, as I mentioned, LDL is the primary target of the therapy and reduction of 50% is what is required. Always and always initial lifestyle changes are recommended. And lowering LDL cholesterol in specific set of people to less than 100 or less than 70 or less than 55 should be done according to his atherosclerotic cardiovascular risk. What this slide tells us is that once you have a significant reduction in LDL cholesterol, if it is more than 50%, you get a significant reduction in events that is less than 50%. If you have significant more than 50% reduction, you will get almost 60% event rate per year. So this is important. So what it tells us is that you need to go low on LDL as much as possible. Same thing from another slide. We can put this as a simpler way to understand rather than figures as percentages is that what is the number needed to get one event less. So if you reduce that LDL cholesterol by about 20%, you need to treat 63 patients to reduce one event per year. Whereas if you reduce the LDL cholesterol by 50%, you'll need to treat only 26 patients to save one patient from having an event. So this is an easier way to understand that LDL reduction benefits are going to be significant. So again, if you reduce LDL cholesterol by 20%, you need to treat 63 patients to prevent one death. Whereas if you reduce LDL cholesterol by 50%, you just need to treat 26 people to save one death. So this is the strength of the LDL reduction, what we can put in as to what we need to go for. So statins are the primary target of therapy in patients for atherosclerotic cardiovascular disease. So always and always, as has been mentioned previously, statins are the best form of therapy which are recommended for LDL reduction. So statins can also be used for reduction in elevated triglycerides always remember LDL is the first target, and once you achieve that LDL target, then you can start looking for triglycerides. One point to be mentioned here at this point of time is that triglycerides therapies, various triglyceride therapies, especially the fibrates, did not show significant reduction in events, and therefore they were not looked up into in a great detail. But newer molecules, especially now icosapent ethyl has been in market, and icosapent ethyl has been shown to reduce the cardiovascular risk. Why the benefit? Why the importance of triglycerides? Once you have raised triglyceride levels, what happens is that the LDL particles are going to be, instead of large fluffy particles, the LDL particles are going to be small dense LDL particles which are high in number, although LDL levels may not be high. So you have large number of small dense LDL particles which can easily traverse endothelium and go into the subendothelial structures, and that can cause increased risk of atherosclerosis. So why now we are putting more stress on triglycerides once we achieve LDL target is that high triglyceride level makes the LDL cholesterol more dangerous for that particular patients, and as has been mentioned previously, this type of dyslipidemia is more commonly seen in diabetic population, and in India this is very commonly seen. We have this diabetic dyslipidemia, so-called diabetic dyslipidemia, where you have low HDL level, not so elevated LDL levels, but high triglyceride levels. And here you have to go for that triglyceride level also. So remember, younger patients, not very high risk, you can go have a little less intense target, but somebody who is more than 40 years who has significant risk factors, you have to go for LDL targets which are less than 70 or preferably less than 50. What do we mean by high intensity statin therapy? So once we know that statins are the primary agents which will be used for treatment of dyslipidemia, the 50% LDL reduction is the benchmark. The statins which will give you more than 50% reduction in LDL cholesterol levels will be rosuvastatin 20 to 40 milligrams or atorvastatin 40 to 80 milligrams. But in the less risk patients, you can use this moderate intensity statin therapy. And what do we mean by that? Something which reduces LDL cholesterol level by about 30 to 50% will be taken as moderate intensity. So what we have in this, rosuvastatin 5 to 10 milligrams, atorvastatin 10 to 20 milligrams, Simva and Prava are not, the other statins are not much used, much commonly used nowadays, but Simva and Prava were initial statins which were available. And pitavastatin does get utilized in some situations where you have statin-induced myopathy or statin-induced diabetes or pre-diabetic people where the LDL targets are not very stiff. You can use pitavastatin, but pitavastatin is still going to be a moderate intensity statin therapy. So patients who are having diabetes and significant risk factors and atherosclerotic cardiovascular disease, we have to go for high intensity statin therapy. Now, amongst the statin therapies, which should be chosen, so we have either atorvastatin or rosuvastatin, and there have been some evidence to suggest that rosuvastatin is probably more potent. So rosuvastatin 20 milligrams is equivalent to atorvastatin 80 milligrams, and rosuvastatin 40 milligrams reduces the LDL cholesterol further by about 5 to 7%. And therefore, patients who have acute coronary syndrome, we should probably be going for rosuvastatin. Remember, a more potent statin, the more chances of having side effects like new onset of diabetes or muscle symptoms. But here, what you are interested in is that saving the patient out from acute coronary syndrome, because you want those patients to have other plaques or other vulnerable plaques which are to be stabilized, and the vulnerable plaque will get stabilized once you have a very intense LDL reduction. So what are the different statin therapies which are available to have intense LDL reduction? So moderate intensity statins will reduce LDL by about 30%, high intensity will reduce by about 50%. So you add ezetimibe to that, you will have LDL cholesterol reduction of about 65%. Only ezetimibe will give you LDL reduction of around 20%. So people who are not tolerant to statins, you can still use just ezetimibe, but remember ezetimibe is a weak lipid lowering agent on its own. So it is to be used only in patients who are not statin tolerant, and therefore you can have ezetimibe. But if you add ezetimibe to statins, high intensity statins, you get about 60% reduction, 65% reduction in LDL cholesterol. One of the new molecules which is being used, especially in young multivessel disease or young recurrent myocardial infarctions, is what is called as PCSK9 inhibitor, which will reduce this LDL cholesterol by about 65%. If you use all the three agents together, that means PCSK9 plus statin plus ezetimibe, that causes LDL reduction of 85%. Of course, that still leaves some risk for coronary artery disease, but you can combine various modalities available for LDL reduction to get stronger and stronger LDL reduction, and which will definitely benefit your patient. So again, the same thing, you have to, all ACS patients, you have to use statins to highest possible target dose or highest tolerated dose. This results in plaque stability. As we mentioned, this is aimed at improving the plaque stability. So you have LDL reduction. The stronger the LDL reduction, you have better plaque stability. So that plaque stability will be seen as reduction in the necrotic core. So what is meant by necrotic core? The patients are taken up for angiography, and we do the intravascular imaging studies like IVUS or OCT, and there we see this necrotic core, which will mean that the plaque is ready to rupture. And once we get reduction in this necrotic core, that means the plaque is getting stabilized. The fibrous cap is going to be thicker, which will mean that the plaque is less likely to rupture. So that is what is meant by plaque stability, which will be seen on angio on coronary imaging by reduction in the necrotic core. Clinically, how it will be seen? It will be seen as reduction in the CRP. So reduction in CRP also occurs if you have significant reduction in LDL cholesterol, and this was what was shown in Jupiter trial. So in Jupiter trial, you had one of the targets was seen as how CRP responded to when we reduced the cholesterol to significant level. So as I mentioned, lipid content of that plaque can be seen to be reduced if we do vessel imaging, which will generally be IVUS or OCT, and that can show that there is a significant reduction in the atherosclerotic plaque volume or atheroma volume, and you can have a significant change in the necrotic core. So this is what is shown in the follow-up studies. This yellow study actually followed up this patient and did the coronary imaging over a period of time after giving them with high dose statin therapy. Now this is what can be seen. This is what is called as IVUS, one of the older studies, a steroid study using rosuvastatin 40 milligrams. What you can see is that there is a significant reduction in the plaque volume after giving the therapy. So the yellow thing around that red thing is what is the plaque atheroma volume. So the red thing inside is the lumen, and the yellow thing outside is the atheroma. And over a period of time, you can see that the atheroma volume has got reduced. So this is what is meant by. So this is what is meant by improvement in the atheroma volume and plaque stabilization. So rosuvastatin showed both reduction in atheroma and lower in LDL levels. There have been multiple studies which will not go into details, but that has definitely shown in improvement of various parameters which we measure on IVUS. IVUS means intravascular ultrasound, where we actually image the artery by ultrasound. So if you are aware of this ultrasonography or echocardiography, it's a similar technique but used for seeing inside the vessel, and it shows that there is a significant various parameters will be seen as going down. So atheroma volume is the most common. You can see the reduction in by about 78%. So plaque regression over 2 years, this is what is meant. IVUS plaque generation can be seen. The simpler technique to be performed on clinical ground will be like carotid intima media thickness. So carotid is very easy to do, and carotid can be used as a surrogate marker for reduction in atheroma volume. And so reduction in intima media thickness can be used as a sort of investigational tool to see if there is any significant reduction in atheroma. Does the risk end here? actually you need to continue this therapy. It's not only for initial year or initial 3 years, but over a period of time, you need to continue with the therapy because you are worried about those, not only the culprit lesion, but the other lesions also can progress and rapidly rupture and cause events. And therefore, over a period of time, you need to continue this therapy. So don't be under the, most of the patients would feel that once they are feeling better, they can stop the therapy. So this is an important thing. We need to inform the patient and impress upon the patient that the therapy has to be lifelong. And if they stop the therapy in between, they can land up with problem. This is another study, carotid intima media thickness, which can tell you. So the mortality benefit is dependent on adherence to statin therapy, and if the patient after some time stops the therapy, then he is likely to go into a secondary event. So that is what is required to be impressed upon the patient. So this lecture cannot be complete, or this talk cannot be complete unless I tell you about what are the new things. So ezetimibe is more or less established now, especially in people who are statin intolerant. We can use ezetimibe 20 milligrams once a day, which will give us about 20% reduction. A new molecule which has been introduced in the Indian market is bempedoic acid. Bempedoic acid is a tablet 180 milligrams once a day. It can cause about 20 to 25% reduction in LDL cholesterol level. But again, as with statins, if we add ezetimibe to bempedoic acid, we can have further reduction to about 36% in patients with ezetimibe and bempedoic acid therapy. So remember, this bempedoic acid is acting at a level earlier than the HMG-CoA reductase level at which the patient, at which level the statins are going to act in the pathway of cholesterol manufacturing. So it is happening at a little earlier level, and this is going to act at an enzyme which is available only in the hepatocyte. That enzyme is not there in the muscles, and therefore has much lower chance of getting into muscle symptoms. So the muscle symptoms will be there only in about 5% or so population treated with bempedoic acid. So this is an important option which is now available for statin intolerant. A little expensive molecule for the time being, but then bempedoic acid and ezetimibe combination is one thing which we can look forward to in patients who are statin intolerant. PCSK9 inhibitor, of course, is a very important therapy. It's already there in Indian market for last few years. The cost is an important restricting factor. It costs about, say, 18,000 per injection, which is to be taken ideally twice a month or every 14 days. But it has a significant, about 70%, 45 to 70%.
सर तुमचा आवाज येत नाहीये.
Deepen?
Hello.
हॅलो सर, लेफ्ट झाले सर, जॉईन करतो 2 मिनिटात. सर आज लेफ्ट.
I think sir is left.
सर जॉईन, सर जॉईन.
नितिन पत्की सर तो दिख रहे हैं.
हाँ सर, आता परत जॉईन झाले, रिजॉईन झाले. सर प्लीज अच्छा ते मोबाईल हे बघत असतील. शेअर द स्क्रीन वगैरे सगळं चालत असेल. सर जॉईन व्हा. जॉईन झाले.
Am I audible?
Yes sir, yes sir.
Yes sir. Yes sir.
Okay. So this last slide basically tells us about PCSK9 inhibitors, which cause about 45 to 70% reduction in LDL cholesterol. Important point to be remembered here is that there is this thing which is called as
Sir, your screen is not visible.
Is it visible now?
Yes, yes.
Yes,
Okay,
yes,
so-
I can see now.
Yeah, so basically these PCSK9 inhibitors cause about 45 to 70% reduction in LDL cholesterol level. The important therapeutic aspect of these molecules is that LPA, which is lipoprotein little a, which is very commonly seen in Indian scenarios or young acute coronary syndromes, is a genetic molecule, a little abnormal lipoprotein, and there is no established therapy to treat that. But it increases the risk of getting coronary artery disease. And the only therapy which causes about 20 to 40% reduction in LPA is PCSK9 inhibitors. So in the Indian market, we have this alirocumab, which is Repatha, which is available now. The expensive molecule. The other molecule is evolocumab, which is still not available in India. Alirocumab was used in little chronic kind of patients, but in acute coronary syndrome patient, we use this evolocumab. But the good news is that there is this new molecule, which is inclisiran. Now, the initial molecules were actually the antibodies to PCSK9 molecules. But inclisiran is a novel molecule in that it is a messenger RNA molecule which stops the production of PCSK9 molecules. And therefore, it is going to be a little more potent and little longer acting. As I mentioned, this alirocumab or evolocumab have to be given twice a month, whereas inclisiran can be given once in 6 months and still has the beneficial effects. So this is all I had to tell you about this acute coronary syndrome. So the way to treat is that all acute coronary syndrome patients will have to be treated with high intensity statin therapy. So maximum tolerated statins are to be used in this particular therapy. That is one. And secondly, go to as low LDL level as possible. And in high risk scenarios, we should be going for LDL level of around 50 or 55. So this is where we should be going for. So I think that's all I had to share for you today. So if there are any questions, I'm not seeing the questions, but if you are any, if you have,
there are no questions, sir. That was for the previous speaker. So it was a very nice lecture, sir. And really the dapagliflozin is really making a wonder, isn't it? Because
Yes.
For the at least cardiologist and nephrologist, they are
Yes,
having,
yes,
rather than patient, because patients are not bothered. They are thinking that a doctor will be treating us, but the doctors are always under tension. So I think it is very much better, isn't it,
yes,
sir?
yes,
Sir.
yes, absolutely.
Thank you very much, sir. So now I will request our President, Madam, Dr. Meenakshi Deshpande, to felicitate you.
Thank you very much. Thank you.
Thank you, sir. Nitin Patki, sir.
Thank you. Thank you for the
Presentation. A bouquet for you from IMA Pune.
Thank you very much. It was very nice. Yes.
Uparna for you.
Oh, that is traditional Pune.
That is a
Yes,
traditional
yes.
Uparna. Yes, sir.
From IMA Pune.
I think you must have received this, I think, 5 or 6 times by now.
Thank you. Yes, yes, yes.
Yes. Thank you,
Thank
sir.
you, sir.
Thank you. Now the next lecture, Dr. Sandeep Murkhandikar. Sir, welcome and good evening, sir. Yes. Yes,
Good
sir.
evening, ma'am. Good evening. Good evening, ma'am.
By the time you can start sharing your screen, so you can take a test also, and I'll be introducing you. Sir's topic is non-diabetic CKD. Is there hope on the horizon of dapagliflozin? So, sir is a consultant nephrologist at Ruby Hall Clinic, in charge of the dialysis department, and he has completed his DM nephrology from Jawaharlal Institute of Postgraduate Medical Education and Research at Puducherry, that is Pondicherry, in July 2015, and he has done his residency at St. GS Medical College and KEM Hospital, Mumbai. So I am also alumni of GS Medical College. He has done his graduation from GMC and JJ Hospital, Mumbai. He has completed his adult fellowship in nephrology at the University of Toronto, Canada in June 2019, which was an extensive 2 years fellowship covering different aspects of nephrology. He has received gold medal for DNB nephrology in June 2016, and his special interests are in the following areas of nephrology: different methods of renal replacement treatment, CAPD, APD, HDF, online HDF, home hemodialysis, etc. And another one are glomerular disease, CKD and pregnancy, acute kidney injury and their outcomes, inherited renal diseases, AD, PKD, and Alpers, etc., and high risk renal transplantation. So over to Dr. Sandeep with this short introduction. Sir, you can start your lecture, sir. Thank you.
Okay. Thank you, IMA once again for allowing me for this topic, which has been uh, really been important nowadays. As we know, India is kind of a center of diabetes for the world, and it's been over a period of time increasing incidence of CKD as well as the diabetes for almost everywhere. There is a good amount of burden or what we can say CKD population in diabetic, and there are majority of the patients, as we know, have a non-diabetic kidney disease also. So a lot of data is being published, multiple trials, and on an average, there is a for every diabetic patients, there is always a chance that they can have a non-diabetic kidney disease also. Almost 40% will have diabetic, and remaining of them have some kind of a non-diabetic kidney disease. The non-diabetic kidney disease is usually in the form of hypertension, sometimes of glomerulonephritis, and other disorders like drug-induced injuries are present. So usually, as we know, people are usually worried about why should we treat CKD, why should we treat CKD. I have this in majority of what presentation I have done in the past. I have shown that usually majority of the CKD management is for the prevention of cardiovascular events, particularly acute coronary syndrome. As we know, GFR once goes down less than 60, there is a very fast progression of cardiovascular disease. And if the GFR is less than 15, they have almost 20%, 20 times more higher progression of a disease. So you can see the majority of the people usually die before the start of a dialysis. This is one of the slide among from the CKD journal of our Jason, and which clearly shows that we can see almost 3/4 of the patients are dying before the start of a dialysis, and only one fourth of the patients are dying when they are on dialysis. Also, overall, the most common risk factor of the cause of death is again is cardiovascular. Others like usually malnutrition, cancers, and infections. So overall, the majority of the death is related to the cardiovascular disease in CKD population. There is a close association, as we know that definitely there is a some kind of a decreased cardiac output, blood flow problem, decreased GFR, decreased function, salt water reduction, performance, chronic heart failure, or volume overload status, and these are propagatory. Difficult to interrupt sometimes because of the difficult volume assessment and management in this kind of a people. So this is a very much coordination between these two, and definitely there is always a renal connection and cardiorenal connection in particular these kind of people. In cardiovascular events increases the risk of incident CKD, as well as the CKD increases the incidence of cardiovascular events, or vice versa. It has been shown. So definitely there is a close physiology and all these things are there. The risk of cardiovascular disease and cardiovascular events are not really increased dramatically as per the CKD progression. We can see no CKD, CKD stage 3A and CKD 5A. You can just think the risk is dramatically increased from stage 3A to stage 5D. So there are a lot of other kinds, non-atherosclerotic cardiovascular disease, left ventricular hypertrophy, cardiac arrhythmia because of the multiple electrolyte issue these people have, sudden cardiac deaths because of multiple other issues like bradycardic death, tachycardic death, ventricular fibrillation, arterial calcification, valvular calcifications, hemorrhagic strokes, infections, stroke, peripheral artery disease. These are all our risk factors for particularly. Uh, uh,
Hello, sir.
yes,
Sorry to interrupt you, but slides are not moving, sir.
slides are not moving. Really?
Just check whether the slides are moving.
Yes, yes, yes. Now,
Now
can you make it in full screen, sir?
I
Sir,
made just
Just now
now.
moving, but make it in full screen, sir. Please.
It's full screen now. It's full screen.
sir,
Yeah. Okay.
click on
Thank you, sir.
enable editing.
Yes, thank you, sir.
The pen is there to guide you.
Okay, I did that. Now, can you see that?
Now, sir, slides have gone.
Are they changing?
No, no, sir,
Sir,
slides have gone
the
now.
screen sharing is in stop. Please share the screen.
1 minute. Can you see now?
Yes, yes, sir. Yes, sir.
Is it changing? Is it
Yes,
changing?
yes, sir.
Changing, it's not changing, sir. You have to convert it into slide mode, sir. Because at the left hand side of mine, sir, other slides are also visible. So what we want is we wanted to have this in a slide deck set so that you can move it and entire slide can be presented, sir.
It's in the slide only.
You have to just turn out into slide mode, sir.
Slideshow.
Yes, sir.
It's a slideshow now. Can you see?
No, sir, it's still the same.
Still same. Okay. I'll stop sharing. Again. Can you see now?
Yes, we can see the screen, but it's not the full screen.
Yeah,
The
I
slides
know.
are moving. The slides are moving.
Okay, now I'll go to the slideshow. Let's see. Now,
No, it's not a full screen.
is it moving?
Yes, slides are moving.
Are you sure slides are moving?
Can you change the slide?
Is it moving?
No.
No, sir, slides are not moving. We can see this evidence suggested that heart failure is like now it is moving.
Yeah, now it's now
No, I think let's do like this only. It's fine.
No issues, sir. No issues. We can continue doing that.
Yeah.
Sorry for
So
the inconvenience.
yeah, it's fine. It's fine. So definitely, as we see, there is one of the component of volume overload is there always present in the CKD population, and there is a good amount of evidence that suggests that there is a very high risk of heart failure, particularly in CKD population. Multiple data are there, and one of the major data was published in heart failure study, and it was the US renal data, which clearly showed that there is a risk of almost 4.25 times CKD patient having heart failure. Along with there are other factors like atrial fibrillation, coronary artery disease, and acute AML. Also, we can see that there is always other factors like we can see stage 2, stage 3, and stage 4 and 5. We can see the percentage of people having heart failure. It randomly goes almost to 45% in CKD stage 4 and 5. So there has to be a particular way to get over this. So let's have a small case. There is a patient with a CKD without diabetes, a 48-year-old gentleman with BMI of 32, no diabetes or major cardiac event, urine albumin creatinine ratio around 200 milligram, 2000 milligram by milligram, and GFR around 40. So he developed hypertension several years, was on hydrochlorothiazide and telmisartan for CKD and hypertension, statins, all this. For the personal history was negative, and family history of negative of diabetes or any kidney disease or autoimmune disorder. And clearly ultrasound the normal this thing, and he underwent biopsy, and biopsy shows of glomerulonephritis, particularly IgA nephropathy. So what is the next line? So definitely there are a lot of studies are coming nowadays, particularly given a DAPA CKD and other trials, and definitely there are other trials having come. Everybody has tried to use RAS inhibitors, and we can see there is a decrease in the residual risk in CKD progression. Almost all the clinical trials, and average is around 12%. So everything is, even in non-diabetic patient where the REAM trial was done, it showed 21% reduction in the protein reduction and progression of a disease. So what is evidence with the HL2 inhibitors in non-diabetic population or any proteinuric disorders which have a CKD with GFR more than 25? So DAPA CKD is one of the really landmark trial published a couple of years back, and has shown clearly it included multiple people like 18 years, GFR more than 25, urine ACR with huge range, patient over on a max tolerated dose of this thing. Exclusion criteria very limited, like type 1 diabetes, polycystic kidney, lupus disease, other vasculitis, and immunosuppressive therapy less than 6 months prior to enrollment, because this usually alter the proteinuria. That's why they have to exclude that. And they were blinded to the placebo, almost 4,300 odd patients, and composite endpoints again, GFR, ESKD, and all these things. Proteinuria, all cause mortality. So we can clearly see that type 2 and mixed populations, DAPA CKD, urine ACR, renal outcomes, GFR, the percentage of patient with GFR less than 60 and urine ACR more than 300 completed this issue trials as compared to the, you can see the number of people in DAPA, CKD or empiric trials were almost, we can see the percentage was almost more than 50 to 60% very severe disease, and that has been very limited trial had this problem. Now the new trial which was going to be published maybe in a couple of months was Emparineal, that has also had a high, almost like the 50-60% people with a lower GFR than less than 30, and we can see that primary outcome of GFR ESKD was pretty good. Patient with diabetes, patient without diabetes, with SGLT2 inhibitor, dapagliflozin, and with the, so overall the relative risk reduction was 50% in patients without diabetes as compared to 36% with diabetes. So this study clearly showed that the use of SGLT2 inhibitors in non-diabetic kidney disease, particularly proteinuria, more than 300 milligram in 24 hours or 300 milligram per gram of creatinine, has clearly shown down to decrease the incidence of CKD in non-diabetic population also. Overall, the albuminuria status in type 2 without diabetes, again with diabetes, again there is a gross reduction in proteinuria, equally statistically significant. So overall, the effect of decreasing proteinuria and ultimately the incidence of CKD or dialysis has been really is going to get down. DAPA CKD was terminated early at 36 months because of very positive data. Definitely, they underwent subgroup analysis. What was the other etiologies or different people category in this population, and we can see diabetic, ischemic, have glomerulonephritis or other unknown cause of any proteinuria, and we can see everything is positive against the SGLT2 inhibitors. All the dapagliflozin is always better in irrespective of diabetic, non-diabetic population, and we can see the proteinuria glomerulonephritis particularly has shown clearly benefit in reduction in proteinuria. Definitely, there is a DAPA CKD had a good number of IgA nephropathy patients. IgA nephropathy, as we know, is one of the most common glomerulonephritis in overall the world, particularly given the Asian country, India, Japan, China, Bangladesh, or more of Asian country. Majority of almost 40% of glomerulonephritis or overall glomerular biopsy shows IgA nephropathy, and DAPA CKD had a very good number of patients. It was like 270. Even the testing trial and IgA trial, these are stop IgA trial. These were the clearly trials which like targeting IgA nephropathy. These are the trials which had only IgA nephropathy patients, no other patients. They had a more patient than their own trials, and we can see the outcome with this trial was very good. The proteinuria reduction cumulative incidence of progression was very less as compared to the on placebo, which was almost 4.4% at the end of 32 months. It is a good trial, as almost at the end of 2.5 years, there is a good control in the proteinuria. So in patient with the FSGs, another subgroup, although the number of patients were less, but all the list, but although whatever we can have the sufficient data to cover, maybe we can say a pilot study of some kind of a disorder when we start having a new type of therapy, and still DAPA was better in almost all kind of FSGs, composite outcome, kidney specific outcome, and primary outcomes. All the outcomes were really better in this study. Although the numbers are very less, but there is a positive outcome in this study. So so definitely we need what happens particularly with the cardiovascular risk or no cardiovascular risk. So we can see the people, we can see this 1, 2, 3, 4, that the dotted is this is a line with the DAPA with the no cardiovascular risk has shown the maximum benefit. Then the DAPA with the cardiovascular risk is the second best, but overall as compared to the placebo, it was very good for the cardiovascular outcome. Overall for heart failure, overall you can see the tremendous effect in the both the categories. It was seen DAPA with heart failure or without cardiovascular defect. So we can see all the patients, heart failure patient, without heart failure patient, the effect of dapagliflozin, there are different parameters. When you apply multiple parameters, once you have a lot of clinical record during inclusion criteria, then you can go on doing this small readjustment and what is happening with the particular disease like heart failure, kidney disease, FSGS, IgA nephropathy, and we get to analyze the effect of these medications. And same way here with our heart failure and without heart failure, overall the benefit is with the very well with the dapagliflozin. Stage 4 CKD, that is what we call is more of an advanced CKD. It is GFR when raises from 16 to 30 ml, particularly advanced that need to be at. Definitely, the DAPA CKD had some a patient, but we can see the stage 4 CKD, which is a very limited volume, is around 40%, and of the this 14%, 64%, 64% had diabetes, and 34% were without, 36% were without diabetes. So what happened to them, like stage 4 versus stage 2 by 3? We can see that although the proteinuria effect or proteinuric effect, anti-proteinuric effect, congestive heart failure effect, or whatever the cardiovascular benefit was less with the stage 4, less, but it was not negative. It was still favoring the use of SGLT inhibitors or dapagliflozin. So overall, the DAPA CKD had advanced patients, advanced category of patients, and we were able to see the overall benefit of the drug across the group, irrespective of what risk factor they had, what baseline disease they had, diabetic, non-diabetic, glomerular disorders, or other kind of a kidney disease where there is a proteinuria. We can say it directly to the proteinuria. So definitely, we can see that there is always a GFR a little bit goes down over a bit of time, depending upon a different stage of a CKD, and usually it stabilizes over a bit of time. And this stabilization is the most important. I have discussed this in multiple my presentations that SGLT2 inhibitors and ACE inhibitors or ARBs, there is a sudden fall of a GFR over a period of 2 to 4 weeks. It stabilizes over a period of time and it remains stable with very minimal fall in a GFR. And it is the same in the same story. Over a period of almost 3 years, the GFR fall was not seen, particularly in the dapagliflozin group as compared to the placebo. Although there is a fall, but it doesn't fall at the end of 36 minutes. It is better than the placebo. So what is the implications of this trial? Definitely, it is a really robust trial, being which used at least 3-4 trials before its inclusion and exclusion criteria, credence trial, empiric trial. And over a period of time, they able to analyze the inclusion exclusion criteria and canvas trial. So at the end of these 3 trials, the DAPA CKD was formulated, and they wanted more severe kind of a patient as compared to the other these 3 trials. And we can see even with the inclusion of severe or higher grade proteinuric patients, lower GFR people, they are getting still benefit. So there is a glomerular pressure reduction. There is increase to glomerular feedback, decrease in the hyperfiltration, decrease sodium hydrogen activity, leading to the blood pressure lowering effect. Neurohormonal improvement is there because of the decreased intrarenal RAS activations, systemic activation. Fibrosis is different because of the proteinuria is getting decreased, and improved oxygenation because less less sodium is being absorbed by the kidneys because of the glycemic effect of this SGLT inhibitors. Automatically, the oxygen requirement goes down. Automatically, the oxygen delivery increases to the rest of the medulla and remote part of the kidney, and automatically, because of the decrease in the inflammation, there is increase in erythropoiesis. All these factors will manifest in automatically stabilization of the GFR, decrease in albuminuria, blood pressure control, stabilization of injury in the form of multiple like ischemic injury or glomerular injury. So over a period of time, these effects are seen, and these effects are usually seen at the end of 3 months in nephrology point of view, or the maximum benefit usually is seen majority of the trials at the end of 2 years, not like a cardiac failure where we start seeing the effect of SGLT inhibitor very early in the trials, sometimes by the end of 4 weeks or 6 weeks. But nephrological trials usually take nephrology benefit of the proteinuric benefit or GFR stabilization. This takes at least 3 months to show the effect. So definitely there have been multiple like what dose should be used, what should be used, follow up, how to do. It is simple like that. GFR should be more than 30, urinacia should be there, heart failure, diabetic population, foot ulcers. Usually there were a complication like peripheral vascular disease. People should not use SGLT, but majority of the trials over a period of time had clearly shown that after the canvas study, having a peripheral vascular disease is not a contraindication of using any of the SGLT inhibitors. Definitely one of the most important protocol, what I can tell you, that sick day protocol has to be informed to these kind of people, perioperative and a foot care, because because of the sudden decrease in the GFR, when you are sick or when you are going for a planned surgery, better to stop SGLT inhibitor, because they are like ACE inhibitors or ARB, can potentiate perioperative or when you are sick AKI because of the dehydrated state of a body because of glycosuria and nitriuria. So this has to be readjusted, and depending upon that, we need to reassess the condition. Usually, a very limited risk of hypoglycemia. Definitely, there is no doubt about that, because it on their own they really don't become hypoglycemic. Patient need to be on some kind of other OHs, and then we can reachieve, yes, resist that. Volume depletion, definitely. If the patient is on good amount of diuretics, particularly CKD patients are on good amount of dose of diuretics, they can become dry. They can have become malaise because of that. And if there is a history of AKI, ongoing AKI, this drug should not be used. This is a stabilization of AKI, because AKI is kind of a volume dynamic situation. Adding a diuretic in the form of SGLT2 inhibitor, where again there is a kind of a volume depletion, which can cause exaggerate the pre-renal component of the AKI. So these the small adjustment in the form of volume supplement, dose of diuretics can reassess the volume, and we need to assess the condition over a period of time. So appropriate patient selection, appropriate way of monitoring in the form of side effects give the best possible benefit of these drugs. So over a period of time, this is one of the last slide of mine, we can see that a declared trial, DAPA-HF trial and DAPA-CKD trial, all the trials have clearly shown the benefit of the this trial, statistically, number-wise, or whatever number we want to see, in the form of heart failure, in the form of GFR, in the form of CKD progression, in the form of dialysis. Means all the parameters of one drug, which I'll say very beautiful, and we can see the numbers in all the trial. If you try to combine, there are more than almost 25,000 patients, and a good amount of data is coming with this kind of people. So we can see, and also the mean GFR, as I told you, is going down and down and down as per the each trial, and the but benefit almost remains the same, causing almost equal benefit in all to the group across the study in this kind of population. So I can definitely say that this is a really very good therapy to watch, and going to be a beautiful drug across the group. And as we are getting newer, more potent or more selective kind of SGLT2 inhibitors, we may benefit with the advantage of these drugs. And hopefully, I see maybe a next decade will be a real change in the management of type 2 diabetes, particularly in the form of considering the cardiovascular benefit and renal benefits these drugs have at present. Thank you.
Yes, sir. Thank you, sir. So there is a hope for the CKD patients, isn't it, sir?
Yes, ma'am.
Yeah,
There is a good amount of hope, and definitely
yes.
with the new advent of this therapy, there have been a good amount of literally in clinical data, irrespective if we collect or don't collect, there is improvement in the kidney function.
Yes, sir. So, sir, our patient madam had to rush to her own clinic. So,
No problem. Absolutely fine.
Navrange sir is also there. He's
Yes.
doing his SSS work.
Yes.
So, on behalf of IMA Pune, sir, I felicitate you with this bouquet, and it's
Yes.
so you can come to IMA anytime. And this is the IMA Uparna, sir.
Yes.
The token of
Thank
love
you.
from IMA.
Yes.
Yes, sir. Sir, it was your wonderful lecture, because it's really needed nowadays, because the people are more and more people are getting affected with kidneys and all. I see many people ask, अरे आम्हाला डायलिसिस करायचंय, कुठे जाऊ, आमचं क्रिएटिनिन लेवल्स एवढं वाढले, 7 वगैरे झालंय. तर म्हटलं हा, so there are many patients, we are getting patients, so it's a real wonderful drug.
Yeah, absolutely. Thank you, ma'am. Thank you.
Thank you.
Okay.
The next lecture is by Dr. Ajit Mehta, sir. And the topic is latest evidence with dapagliflozin and ticagrelor. So implications to practice. So welcome, sir, and namaskar, sir. Dr. Ajit Mehta, sir. Yeah.
I think.
So, yes,
Can
sir.
you see my slides, madam?
Yes, sir. Yes, sir. Yes, sir. We are doing that, sir.
Yeah. And then you can hear me as well, right?
Yes, sir. Yes, sir. I'll introduce you to all the delegates. Sir is a cardiologist in Pune. He's practicing at Jahangir Hospital, which is an associate hospital of the Apollo Hospitals Group. Apart from routine coronary angiography and angioplasty, Dr. Ajit Mehta also has expertise in complex coronary angiography such as bifurcation, arthrotomy. He also has considerable experience in primary coronary angioplasty, pacemaker implantation, biventricular pacing for chronic heart failure, and ICD implantation. He has a keen interest in pediatric cardiology and device closure for atrial septal defect and patent ductus arteriosus, that is PDA and ASD. So over to sir. With this short introduction, I will request sir to start his presentation.
Madam, thank you very much for your kind introduction, and thank you IMA for giving me this opportunity to talk on the latest evidence on dapagliflozin. As we all are aware, the SGLT2 inhibitor, mainly dapagliflozin and empagliflozin, which has been there with us for a while. And we know that SGLT2 inhibitor is good to reduce glycosylated hemoglobin to get sugars under control. But recently, it has become a major part of our management of our heart failure patients. So it's not only a molecule to be used by diabetologists, but we as a cardiologist also have been using this molecule very, very often nowadays. So with that, let's see a case presentation. 58 years old gentleman, smoker, non-diabetic, was rushed to emergency room with signs and symptoms of the heart failure. He was diagnosed with ejection fraction of 38%. So this gentleman who has had never history of any diabetes or any other problem was rushed with a heart failure with ejection fraction to emergency room. In emergency room, he was put on a conventional medical therapy like statin, beta blocker, ACE inhibitor, and was discharged subsequently. At the time of admission, his BMI was 24, BP was 130/90, triglycerides were okay, slightly high, ejection fraction was 38%, less than 40%. We consider severe LV systolic dysfunction. Patient had eGFR of 50. So this patient was put on the conventional therapy of beta blocker, ACE inhibitor, statin, and was sent home. After a few days, after about a month, patient came back with worsening of the symptoms of the heart failure. From NYHA class 2 to 3, he had NYHA class 3 to 4, and his ejection fraction further dropped down by about 5%. From 38%, his ejection fraction came down to 5%. So this is a case just to summarize what happens in our daily practice. So a patient who comes to us with heart failure with reduced ejection fraction, we start them with ACE inhibitor or ARB. If they are congestive symptoms, we give them loop diuretic for a while. We give them beta blocker, we give them statin, and we send the patient home. So what does the guidelines evidence says? Is the right way to treat this kind of patients, or how one should go about it? So if you see, heart failure is a major public health problem. Prevalence is increasing day by day, especially with increasing age, aging population, diabetes, hypertension, associated coronary artery disease in India, multiple risk factors. So though it is ever increasing prevalence of heart failure patient what we see in India. And repeat hospitalization occur frequently during first few months after diagnosis of heart failure and after probably discharge of for the heart failure. Guideline-directed medical therapy is often not being used. We have been given the guidelines by so many organizations. This is a typical guideline one should use to treat the patient with a heart failure with reduced ejection fraction. But generally, we still stick to conventional practice, what we have been having it for the last so many decades. Adherence to guideline-directed medical therapy reduces the risk of all-cause mortality and hospitalization for heart failure. Patients who receive earlier and simultaneous initiation of guideline-directed medical therapy achieve better clinical outcome than patients who receive conventional sequencing of heart failure medication. So as we just mentioned, the repeat hospitalization or the worsening of the symptoms are generally seen more during first few months after diagnosis of the heart failure or after discharge for the heart failure for the first time. And as well, there was an increase in the major adverse cardiac event during first few months of initiation of treatment or probably diagnosing of the heart failure in this patient. So what it means that we should treat, or we should hit hard in the initial part of the treatment in this patient. So once patient is diagnosed with heart failure, probably more than sticking to our conventional therapy of ACE, ARB, beta blocker, we should definitely follow guideline directed medical therapy, a comprehensive therapy. So if you see the data from various trials, we have seen people who were given comprehensive therapy, which includes all 4 major drugs. That includes ARNI, beta blocker, mineralocorticoid receptor antagonist, and SGLT2 inhibitor. So this is a comprehensive therapy which is given in a guideline directed medical therapy versus conventional therapy what most of us have been using, like ACE, ARB plus beta blocker. There was a significant reduction in the event-free survival between these two groups, more than about 6 years. So dapagliflozin and prevention of adverse outcome in a heart failure trial. We all know the landmark trial, DAPA heart failure trial, the largest and first ever trial done with SGLT2 inhibitor for heart failure with reduced ejection fraction, has successfully showed to improve outcome and symptoms. There were about 4,700 patients, 1:1, double-blinded randomization with dapagliflozin and placebo. Mind you, only 45% of these patients were type 2 diabetic, and 55% of the patients did not have diabetes. So non-diabetic patients were more in this study group. What does study results show? There was a significant reduction in the composite of CV death and worsening of the heart failure. The CV death was reduced by 18% and heart failure hospitalization by about 30%. There was a consistent benefit across the board and representative of population, like whether patient was diabetic or non-diabetic, background heart failure therapy, whether patient was on ARNI, not on ARNI, use of diuretic dose. So across the board, usage of dapagliflozin has shown to be effective and to reduce CV death and heart failure hospitalization in this patient. The risk of both first and recurrent heart failure hospitalization was also reduced. There was a reduction in all-cause mortality, improvement in the heart failure symptoms, more common, and deterioration was less common. There was significantly reduced risk of CV death or worsening heart failure as early as 28 days. We'll see that in the next slide. And well tolerated in patient with or without type 2 diabetes. Adverse events rarely led to discontinuation of the treatment. No events of major hypoglycemia or decay in patient without type 2 diabetes. So this is what the point I was making here. So if you start patient on SGLT2 inhibitor, you start curve separating as early as 28 days. So the effect or reduction in the CV mortality, repeat hospitalization for heart failure was seen as early as 28 days after initiation of SGLT2 inhibitor in this patient. This is a very important slide. What it says, whether dapagliflozin offers significant CV death reduction when used immediately after ACE, ARB, or beta blocker. So this is an exploratory post hoc subgroup analysis. We showed even when dapagliflozin is added over conventional therapy like ACE, ARB, or beta blocker, there was a significant reduction, almost like 40% reduction in the CV death in this patient. So what the slide, why it is important, we all know today, ARNI has become mainstay of treatment in the heart failure with reduced ejection fraction, but dapagliflozin has added or probably has definitely added advantage over and above ARNI and other important molecules in the management of heart failure with reduced ejection fraction. DAPA-HF, composite of ventricular arrhythmias, resuscitated cardiac arrest or sudden cardiac death was also significantly lower as compared to placebo. There was 21% relative risk reduction, and it also has effect ischemic versus non-ischemic etiology in both the subgroup, where the patient had ischemic heart failure with reduced ejection fraction or non-ischemic HEPREF. There was a significant reduction with who were given dapagliflozin. In KCCQ score, at the end of 8 months, there was a significant improvement in patients' quality of life. The second most important or widely used SGLT2 inhibitor, empagliflozin, also has more or less similar benefit as dapagliflozin. So how should we implement this drug, dapagliflozin, in clinical practice for the treatment of HEPREF patient? The cornerstone of the therapy, we have 4 important drugs. One, ARNI, beta blocker, MRA, SGLT2 inhibitor. And if patient has a signs and symptoms of congestive heart failure, probably one should give loop diuretic to start with. But once it's very important for us to understand, once patients congestive symptoms disappear, we should reduce loop diuretic, because patient is already on MRA. That is also, though not a very potent diuretic, that also works as a diuretic. And importantly, SGLT2 inhibitor is known to cause osmotic diuresis. So we have 2 additional diuretic. Unless patient has very gross signs and symptoms of congestive heart failure, you can add loop diuretic to this to the patient. And once the symptoms disappear, probably epidural edema goes, patient can sleep comfortably. Loop diuretic should come off as early as possible. And all these drugs are class 1 indication. People who have LV ejection fraction less than 35% with QRS duration less than 130. If it is ischemic, probably you should consider ICD class 1 indication. Non-ischemic LV dysfunction with less than 130 QRS duration, probably class 2 indication to consider ICD to reduce sudden cardiac death in patient. If patient has LV ejection fraction less than 35% and QRS duration more than 130, how do we go about it? If patient has, probably you can consider CRTP or CRTD, that is cardiac resynchronization therapy. So it's kind of a pacemaker which is implanted the way we do normal pacemaker implantation. Have 1 lead in right atrium, have 1 lead in right ventricle, and LV lead goes into coronary sinus. And we try to, when patient who have left bundle branch block with wide QRS more than 130 or 140 milliseconds, they have interventricular and intraventricular dyssynchrony, which also is responsible for LV dysfunction. So we try to reduce this dyssynchrony between 2 ventricles and between septum and the posterior wall of left ventricle, and try to minimize this dyssynchrony to have a better LV ejection fraction. So a person who has a LV ejection fraction less than 35% with wide QRS, particularly left bundle branch block, and they are on optical medical therapy, are still symptomatic, and if QRS duration is between 130 to 150, class 2A indication to consider CRTP or CRTD. And if it is more than 150, definitely you should consider CRTP or CRTD in this patient. What should be the sequence of events in this treatment? We all know, most of us probably have been treating this patient on a conventional treatment strategy, but there is a limitation in this approach. What happens, because we generally start giving patient a single drug, up titrate to the maximum tolerated drug, wait for other important drugs to add on, because we don't know whether the patient would tolerate that treatment or no. And once patient is comfortable with one particular drug, then we add a second drug. But continuing all this conventional approach, probably we takes about 6 to 8 months to give all the drugs, which is not right. So what it happens, actually, there is a delay in starting therapies demonstrated to reduce morbidity and mortality within first 30 days of treatment initiation. It assumes that most effective and well-tolerated treatment were developed first, assumes the foundational treatment are effective only when titrated to target dose, and assumes each drug was tested in environment where patients were receiving all background therapy at the target dose. So in conventional therapy, we generally start patient on ASARB, after a few weeks, we start patient on beta blocker because we don't know whether patient would tolerate both the drugs. Patient will get into hypotension or no. Then probably add MRA. Then, as guidelines are directed, probably switch over from ASARB to ARNI, and then add last SGLT2 inhibitor. But if you do this conventional approach, probably it takes about 6 months to add all the therapies. But as we have seen, SGLT2 inhibitor added within first month or probably before discharge of the patient with the heart failure reduces CV mortality and repeat hospitalization. So it should be added as soon as patient is diagnosed with heart failure. So the rapid initiation of the first line treatment for heart failure with reduced ejection fraction in 4 weeks. Treatment with all 4 first line therapies. First line 4 therapies are SGLT2 inhibitor, beta blocker, ARNI, and MRA. So should be initiated within 4 weeks since onset of signs and symptoms of the heart failure. Adding a new drug class yields greater benefit than dose titration of existing agents. Morbidity and mortality reduce even with low starting doses. So probably we should try and incorporate all 4 major drugs ASAP more than trying to escalate the dose of each drug. Magnitude of treatment benefit of each drug class independent of the background heart failure with reduced ejection fraction therapy, and improvement and safety and tolerability. So the step 1 is to simultaneous initiation of beta blocker, SGLT2 inhibitor, because we all know that heart failure with reduced ejection fraction, most of the patients have got borderline blood pressure. So if you have a patient who has blood pressure of say 100 systolic, putting them on both beta blocker and ARNI or ACE inhibitor for that matter will not be feasible at times, because we want blood pressure to be at least 100 plus when we are giving 2 antihypertensive drugs, particularly ARNI or beta blocker. And we know beta blocker is proven to be reduce mortality in patient with heart failure, HFrEF patient. So beta blocker and SGLT2 inhibitor should be given if patient have borderline blood pressure. If patient's BP allows us, within a week or 2, we should put patient on ARNI, and in a week or 2 probably add MRA. So these are the first 4 frontline drugs we should be using in patient with heart failure with reduced ejection fraction. This is a very busy diagram which shows depending on patient's clinical status, whether patient's blood pressure is less than 90/60, whether patient's BP is more than 90/60, what is the patient's heart rate, whether patient is a CKD patient or no, patient who has atrial fibrillation. So depending on a clinical condition, probably you may start SGLT2 or SGLT2 again. If you see in this diagram, SGLT2 is started as a first line therapy in all the patients, irrespective patient has diabetes, no diabetes, whether patient's BP was less than 90, whether patient had tachycardia, bradycardia, CKD patient. Of course, again, when we talk about CKD patient, we can use dapagliflozin if eGFR is more than 30, and empagliflozin can be used up to eGFR more than 20. So this is only limitation for using SGLT2 inhibitor. But apart from that, SGLT2 inhibitor becomes first line therapy in most of these circumstances. And depending on patient's other clinical condition, probably you can go either with beta blocker, ivabradine, or ARNI, or diuretic, or MRA in this patient. So this is how I end my presentation here. If you have any questions, please go ahead and ask me.
Sir, till now there is no question, but it was a real good, nicely explained thing. And about the SGL2 inhibitors, I have observed that it is really making आपण म्हणतो काय एक वरदान मिळालं आहे लोक म्हणजे हार्टच्या पेशंटना, कार्डियक as well as renal patients. So it's a real good drug, sir.
Yes,
so
absolutely.
with this, sir, our madam has gone home to the clinic. So I'll be felicitating you on behalf of IMA Pune. Sir, this is a bouquet for you. You can come anytime to IMA Pune to collect this, and you can visit our IMA Pune building.
Thank you, madam. Thank you very much.
Thank you very much, sir. Thank you very much, sir.
Okay.
Yes. Yeah. Good evening and namaskar, madam. Dr. Pratibha Phadke, madam. Madam join झाले आहेत मला वाटतं. मॅडम has joined, no? Phadke madam?
Yes, madam has joined.
Madam has joined. Yes. Namaskar, madam. Yeah. Now the last lecture is on rewriting the guidelines in the management of diabetes and its complications by dapagliflozin. It is by our madam, Dr. Pratibha Phadke. She is practicing consultant physician for last 30 years, and she's a consultant at Dinanath Mangeshkar Hospital. She is a DNB teacher also, and she's got special interest in diabetes, in particular gestational diabetes and infectious diseases. So with this short introduction, I will request my madam to start her presentation.
Hello.
Yes, madam, you are audible.
Yeah.
Yes, sorry, madam. My this computer was muted, so I'll again introduce you. And good evening and welcome to this webinar. Your last lecture, madam. I think you are muted. Please see. Yeah. So I'll introduce you. Madam is a practicing consultant physician for last 30 years. She's a consultant at Dinanath Mangeshkar Hospital. She is DNB teacher, and she has got special interest in diabetes, in particular gestational diabetes and infectious diseases. So over to you, madam. You can start your presentation.
Just a minute.
Yes.
Good evening to all. I think I've heard a lot about dapagliflozin, and we have heard a lot of studies.
Yes.
And how it had changed. I think Dr. Mehta is still sharing his screen.
Acha, it is his screen, or what?
Yeah, okay, so okay. I can't share my screen.
Dr. Mehta, sir, please unshare your screen. Dr. Ajit,
yeah, I will just tell, sir. Just a minute. I will just tell, sir.
Yes.
Yeah, so in the meantime, we can start. I think you have heard a lot about dapagliflozin in last 3 hours, almost 3 hours. And we are going to hear about it, I think, and use it almost daily. It acts on pumps, filters, and pipes, all three, and diabetes. So how it has changed the guidelines? Actually, these new molecules which have come, GLP-1 analogs, DPP-4 inhibitors, and SGLT2 inhibitors are new molecules, and they have generated a lot of evidence and compelled us to change our guidelines for treatment. Actually, till about 2-3 years ago, diabetes management was focused just on glucose, managing glucose, controlling glucose. But now, as we can address all the complications of diabetes, like microvascular as well as macrovascular, our aims have changed. And with these new molecules, we are able to address all the complications from the beginning. Slide. So they have compelled us to rewrite the guidelines for management of diabetes and its complications. This is a typical type 2 diabetes patient who is smoker, hypertensive, and dyslipidemic. He's 67-year-old, male patient, has 10 years of history of diabetes. There is no history of myocardial infarction, stroke, heart failure, or angina. So at present, he has no CV risk actually, according to the history. His HbA1c is 8%, which is uncontrolled. His LDL is 83, which is fairly okay. his weight is, BMI is high, his GFR is good, and BP is well controlled. This is a type of patient which we see daily in our OPD, in day-to-day practice. He is already on gliclazide, metformin, vildagliptin for his diabetes, telmisartan, hydrochloride, amlodipine for hypertension, and rosuvastatin for his dyslipidemia. So what more can we do for him? What is his atherosclerotic cardiovascular disease risk? Is he at some stage of heart failure? And is he having some complications related to kidney? So let us see what we can do for him. As you can see in this slide, this was a study conducted in India in 2014. If our aim was only to control HbA1c, still we are failing in about 67% of patients where we don't reach the target of 7% of HbA1c. Only 33.1% of diabetic population in India who is taking treatment achieves the goal of HbA1c of 7%. This 7% is supposed to reduce the risk of patient getting into microvascular complications of diabetes. Going back to our patient, he is at this stage now where he has multiple CV risk factors. He's a smoker, he's overweight, he has hypertension and dyslipidemia. Can we do something at this stage to reduce his risk of heart failure hospitalization, chronic kidney disease, and atherosclerotic complications? What is a natural history? If such patient comes to us, within 5 to 10 years, he'll develop one of the cardiorenal complication or some atherothrombotic, eventually he will land into either CKD or heart failure. So can we intervene at this stage where he doesn't have any complication of atherosclerotic cardiac or renal event? So this is the window of opportunity for cardiorenal prevention. He is at the stage of left ventricular dysfunction or hypertrophy and new onset of albuminuria. So heart failure or CKD are the at the presentation in type 2 diabetic patients rather than myocardial infarction. So this is a study, retrospective analysis of population data in various countries, which has shown that first comorbidity identified in patients who don't have any cardiovascular event, CV-free patients, first event is either heart failure in 24% of the patients or CKD in 36% of patients. Rest of the patients have either peripheral vascular disease, myocardial infarction, or stroke. So compared with comorbidity-free patients with type 2 diabetes, they have cardiorenal disease at the beginning. If we see albumin to creatinine ratio in patients of diabetes, which is just 30 to 299, that is microalbuminuria, the hazard ratio is 1.5, which is equivalent to hazard ratio of glomerular filtration rate, which is less than 45. So microalbuminuria is equivalent to having glomerular filtration rate of almost less than 45. So the risk is high even with small amount of microalbuminuria. How do we place dapagliflozin in these cases? And we provide a window of opportunity to prevent complications of cardiorenal complications. How do you SGLT2 inhibitors act? What are the potential benefits of using SGLT2 inhibitors? They are, of course, glucose lowering agent, They reduce because of lowering of glucose, lowering of HbA1c, they reduce the microvascular morbidity, decrease the glucotoxicity. They are insulin independent in their mechanism of action and have therefore ability to work at all stages of diabetes because of their insulin independent action. They cause osmotic diuresis. So there is initial weight loss because of osmotic diuresis and decrease in blood pressure. So what is the ideal blood pressure we should maintain in a diabetic? It should be less than 130/80, and we should aim for it by giving them various drugs. There is loss of excess calories which we consume through the urine because of glycosuria. So there is further sustained weight loss in these patients. And because of other OHs which we use like sulfonylureas or pioglitazone, there is weight gain. And there is mitigation of this weight gain because of use of SGLT2 inhibitors. So these are the various potential clinical benefits of SGLT2 inhibitors. As I said, they just don't work on kidneys. They have other favorable effects on other organs, like they decrease incretin effect, increase lipolysis, increase glucose reabsorption, decrease glucose, increase insulin, increase neurotransmitter dysfunction, and so improve cognitive function in diabetic patient, which is important part. They reduce endogenous glucose production, EGP, in the liver. They reduce glucagon secretion and improve beta cell function. So they have actually multimodal effect in diabetic patients. Their glycemic efficacy is also fast. Onset of action is fast. They cause glycosuria for almost more than 2 years. And there is 1.2% HbA1c reduction by week of 24. And overall, above the other OIDs which we use, they cause more HbA1c reduction. So here in this slide, it is shown that if used along with metformin also, or add on to metformin, they reduce the HbA1c by 1.2%. Depending upon whatever the basal HbA1c, in each case, they reduce the HbA1c level further when used along with metformin. It has been shown that they reduce the hypertension also. There is weight reduction also. For each level of BMI, like if the BMI is normal, the reduction in weight will be 1 kg. If the BMI is more than 40, the reduction in weight will be by 3.4 kg. So depending upon baseline BMI, there is further reduction in weight. And depending upon baseline blood pressure, with the use of dapagliflozin, there is more reduction in systolic as well as diastolic BP. So they have really multimodal effects. At 52 weeks, reduction of HbA1c was actually almost equivalent to sulfonylurea. So actually insulins reduce our HbA1c at maximal rate, sulfonylurea next. So at 52 weeks, SGLT2 inhibitor like dapagliflozin reduces HbA1c almost to the level of glipizide. There is more than 10 times lower incidence of hypoglycemia with the dapagliflozin. As we know, with sulfonylurea use or with insulin use, there is a lot of incidence of unrecognized hypoglycemia. With SGLT2 use, the hypoglycemia risk is also very low. Also, again, here it is shown that there is blood pressure reduction with the use of SGLT2 inhibitor like dapagliflozin. Here in this study, dapagliflozin was studied versus sitagliptin, which is a DPP4 inhibitor. and cardiometabolic risk factors were studied in Japanese population, and it has been shown that dapagliflozin was superior to sitagliptin regarding several secondary endpoints, namely reducing fasting plasma glucose, insulin, uric acid, increasing high density LDL. Slide change. DPP-4 inhibitors are neutral on MACE events and recurrent admissions for heart failure. MACE is major atherothrombotic cardiac events. DPP-4, these are various trials. SAVOR-TIMI is for saxagliptin, EXAMINE for alogliptin, TECOS for sitagliptin, and CARMELINA for linagliptin. And if you see this, they are neutral regarding various MACE events. And again, only few like SAVOR-TIMI has reduced rate of heart failure readmissions, but the other DPP-4 inhibitors have neutral or low effect on heart failure. This is a snapshot of various cardiovascular outcome trials. Each bubble represents the size of the trial, and in pink, in blue, it has been shown that this is DECLARE-TIMI, which is done for dapagliflozin, and here it has been used in patients who don't have any cardiovascular risk at the beginning, and still it has shown that use at this stage, that is when there is no cardiovascular risk, it reduces further cardiovascular events. These are various small trials which have shown they've used it in patients who have already cardiovascular risk, and they also reduce the further events. But importance of dapagliflozin comes where at the baseline only it reduces the cardiovascular event risk. This is likely which patients we see in primary care, like the patient which was shown earlier. This slide, we show dapagliflozin 10 milligram versus placebo, multiple risk factors, no prior cardiovascular event. For primary prevention, if it is used, like in our patient, the risk reduction is by almost 59%. There is atherosclerotic event risk, but no prior myocardial infarction. The risk reduction in all further stages like prior MI, risk reduction is almost by 40%. So this is very significant risk reduction in various stages of major atherosclerotic events. So this is the window of opportunity where we can use dapagliflozin, where multiple risk factors are there, but no actual event is there. Like our patient had smoking in his history, diabetes, uncontrolled, hypertension, dyslipidemia. So this is the time, if we use this, we can reduce the risk of atherosclerotic event like stroke or infarct by almost 60%. This is confirmed again by DECLARE trials, which has, this is safety experience in DECLARE trial, where almost 70,000 patients were studied for more than 4 years. What are the adverse events we can see? Treatment-related serious adverse event, percentage with placebo is more than DAPA. Treatment emergent adverse events leading to drug discontinuation was just 8%. Major hypoglycemia less than placebo actually. Diabetic ketoacidosis, which we are worried about with the use of SGLT2 inhibitors. It can usually cause non-hyperglycemic ketosis. But as you can see here, only 0.3% amongst these 17,000 patients had decay. The risk of amputation is high, but it is almost equal to placebo in this study. Risk of fracture again is almost equal. Acute kidney injury, if used judiciously, like stopping it before any major surgery or in the event of dehydration, can reduce the risk of acute kidney injury. And in this study, it was less than placebo. Symptoms of volume depletion were almost like placebo. Genital infection, which we are worried about, was less than placebo. Urinary tract infection was almost equivalent to placebo. Fournier's gangrene, which is a reported side effect of all SGLT2 inhibitors actually, was less than placebo. And cancer of bladder was also almost equivalent to placebo. So it is backed with wealth of experience with over 2.5 million patients treated across more than 90 countries. So we can safely use dapagliflozin provided we keep a watch on dehydration and take prompt action when patient has suffered from urinary tract infection. So the story so far is like initially we were targeting blood glucose, avoiding obesity and treatment of comorbidities like dyslipidemia, hypertension, with use of SGLT2 with caution as a third or fourth line agent. That was the guideline earlier. And now we were using only for secondary prevention till 2018. And now in 2022, the guidelines are recommending SGLT2 inhibitors for primary prevention when there is window of opportunity. I think most of the speakers have shown this slide. This is a very busy slide. Here, when a patient comes to you, you are not just supposed to target his blood sugar and HbA1c. You are supposed to assess the risk by ASCVD risk by various calculators which are available online and determine the CV risk. See, ASCVD takes into consideration your age, your LDL, HDL, and total cholesterol levels, and your status of diabetes, then hypertension, smoking status, and calculates probability of getting a CV event at the end of 10 years or within 10 years. Also, there are various risk enhancer which are taken into consideration, like family history of early atherosclerotic events like stroke or MI, high LDL levels more than equal to 160, history of CKD, history of metabolic syndrome, presence of metabolic syndrome, then history of preeclampsia, history of premature menopause, history of inflammatory diseases like rheumatoid arthritis, and of course, most important is South Asian ancestry, like we land up in that category, and high triglyceride levels. In Indian diabetic patients, high triglyceride levels are very common, and which was nicely addressed in Dr. Patki's lecture, where triglyceride levels are more than 175. We have to take that as risk enhancer, and we should aim at using primary prevention with the use of SGLT2 inhibitor. In NICE guidelines, here it is shown the guidelines of American Diabetic Association, but even in European guidelines and NICE guidelines, SGLT2 is staged at after metformin or with metformin if ASCVD risk at the end of 10 years is more than 10%, or if sugars are not controlled. You can use it with various other oral hypoglycemic agents or with insulin also. So SGLT2 is recommended independent of glycemic control. Even if your HbA1c is under control, but if your risk of getting ASCVD is high, if you have albuminuria, so you can use SGLT2 inhibitor. So at the beginning, when patient comes, you have to assess the risk for ASCVD score, and you have to do microalbuminuria or albumin creatinine ratio and design the therapy to primarily prevent ASCVD risk and CKD risk. So ADA 22 guidelines recommend SGLT2 inhibitors. And here various SGLT2 inhibitors which are available, dapagliflozin, canagliflozin, and EMPA have been compared. And various trials are there which show that dapagliflozin works for reduction in heart failure and reduction in CKD progression in various cardiovascular outcome trials. There is also primary renal outcome data, which we have seen in previous lectures, and primary heart failure outcome data, which we have seen in previous lecture. So it scores in all three, and I think one of the best and most studied drug for all three. So here is another patient who is 65-year male patient who has history of coronary artery disease and hypertension. He had heart failure with reduced ejection fraction 3 years back, with more than 5 hospitalization, recurrent hospitalization in last 2 years. His NT-proBNP is 1900. He is on beta blocker. His ejection fraction is 35%. He's on S inhibitors. There is no history of diabetes. His urinary albumin creatinine ratio is 600 milligram. He's on MRA. His chief complaints are dyspnea at rest, NYHA class 4. His eGFR is low, and he has sign of mild pedal Since his last visit about 4 months back, his NT-proBNP has been raised by about 300, and his eGFR has declined, and his urinary albumin creatinine ratio is increased by 10%. So what is the next line of heart failure and CKD management? Actually, which we have seen in earlier lectures in DAPA-HF trial, where almost 5,000 patients were treated, both non-diabetic and diabetics. Like our patient who is non-diabetic, DAPA 10 milligram was used and placebo was used. And it was shown that almost 26% risk reduction was there, and numbers needed to treat were only 21 for reducing recurrent heart failure admission, and risk reduction for CV death was 18%, and risk reduction for recurrent heart failure hospitalization was by 30%. So in our patient, if we use dapagliflozin, there will be significant reduction in his recurrent admission. DAPA was well tolerated in patients with or without type 2 diabetes, and adverse events rarely led to discontinuation of treatment. And no event was there where there was major hypoglycemia, decay in patients without type 2 diabetes. So we can safely use it in patients with heart failure without type 2 diabetes, without thinking of risk of hypoglycemia. There are 2 important trials of SGLT2 inhibitors for heart failure in reduced ejection fractions. One is with DAPA and one is with EMPA. So here various parameters are seen. Heart failure recurrent hospitalization reduction is almost same. CV death reduction was majorly shown in DAPA-HF trial, which was 18% versus 8% with EMPA. All-cause death reduction was 17% with DAPA, and EMPA was 8%. Onset of new diabetes in pre or non-diabetic population, 32% reduction in onset of new diabetes, and 14% with EMPA. ejection fraction benefit was consistent across all spectrums of ejection fraction. And here there was no benefit if ejection fraction was between 30 to 40%. And change in quality of life score with DAPA was plus 6.1 and with EMPA was 5.8. Renal endpoints, renal death included 29%, and in EMPA renal endpoint there was significant reduction 50%, but they didn't include renal deaths. So almost in all aspects, DAPA has scored well. So this actually we have seen in last lecture that in heart failure, you start treatment with simultaneous initiation of beta blocker and SGLT2 inhibitor, and within 1 to 2 weeks you go to ERNI, that is neprilysin inhibitor with ARB, and then you go to mineralocorticoid receptor antagonist. So you start everything within 4 weeks, and which gives maximum risk reduction. What about chronic kidney disease? The first treatment of patients with CKD is in DAPA CKD trial. It has been shown that they have treated almost again more than 4,000 patients. All patients have received DAPA 10 milligram versus placebo. 32% patients had no diabetes and 68% had diabetes. As we have seen in earlier lecture, that even in non-diabetic patients, DAPA works very well for CKD patients. There was 39% risk reduction, 36% in patients with type 2 diabetes, and 50% in patients without diabetes. So DAPA for filters, that is kidney, acts on CKD, and results are consistent in patients with or without diabetes. And it is the first renal outcome study to show robust benefits. And it has recurrent heart failure admission CV benefit in CKD patients consistent with other trials. And it it acts in primary prevention of CKD as well as heart failure. So how do we go about treating CKD patients? First, we initiate lifestyle therapy, that is reduction in weight, nutritional adjustment, and physical activity. Then first line therapy for diabetic patients, if eGFR is more than 30, we discontinue metformin. If it is less than 45, we reduce the dose of metformin. And simultaneously, we start SGLT2 inhibitor. Generally, if eGFR is less than 30, we do not initiate dapagliflozin. And if patient is on dialysis, we stop dapagliflozin. Additional drug for sugar control, we can use GLP-1 analog, DPP-4, insulin, almost any OHA with this therapy. So dapagliflozin now covers the entire spectrum for cardiorenal risk reduction. As we have seen in last lecture also, various trials like DECLARE, DAPA-HF, and DAPA-CKD, it has been shown that CV death, recurrent heart failure, hospitalization, and CKD progression, in all three aspects, DAPA works very well. So how can we ensure that better efficacy or outcome? So here again, innovator drug, which is crystalline, is pure as compared to other bioequivalents which are amorphous. Crystalline molecule is more stable at higher temperatures also. And so we should try to use the innovator drug, which has undergone many trials and shown sure benefit. So this is my last slide. thank you for giving me opportunity. Thank you, IMA. And if any questions are there, I'll be happy to address.
Yes, madam, it was a wonderful lecture and your slides were very explanatory. So about that dapagliflozin trial, more than 2.5 million patients have been tested with in 90 countries. 90 countries, isn't it? So it was a very good trial, so that we can see the efficacy of the drug also, and all this. And the other slide was also nice, in where it has been shown that all the various effects, rather than cardio and renal, other effects also, that is dyslipidemia and all. So it was really, all slides were very nicely seen and they were quite good. So thank you very much, madam. There is no question. If you want to add something, you can add. I think that will be okay. If you want to tell something from your personal experience.
Take home message will be, when the diabetic patient comes, don't just look at his sugars, look at other factors, assess him for cardiovascular risk, and track his albumin secretion in the urine, check his ACR at the beginning, and address all aspects at initial level. So really we can help our patients to prevent getting CKD or getting any cardiovascular event like stroke or peripheral vascular disease too. I think that will be our take-home message today.
Yes. As a treating physician, you have to be very much aware about the complications to happen. So if you take proper this thing management, then it will be better. And with this new drugs, it is really making wonder with the patients. So very nice. So thank you very much, madam. And I think there are no questions. So we can, I think we can conclude this session. So it was a wonderful session. All the speakers, they spoke very well. And with this, I will felicitate madam on behalf of IMA. Our president madam had patients, so she had to rush to the clinic. So she's not there. I am Dr. Alka Kshirsagar. I am a retired gynecologist. So I can wait here. So this is a moment. This is a token of thanks, madam, from IMA. This is a napkin bouquet. And this I can just show you. You can come to IMA anytime.
Yes, sure.
And this is the IMA Uparna, a token of love from IMA Pune.
Thank you.
Yes, madam.
And thank you for sparing your valuable time. Both of you, actually, it might have been boring for you, but
no, not boring, madam. We had that. We have just finished 12 module diabetic course. So that diabetic foot, one specialist, he told that every foot is diabetic. Once the patient is diagnosed diabetes, every foot is diabetes for that patient. You cannot say when the something goes wrong. So the same message you have told now. Yeah.
We always tell our patients to do Padya Puja of all patients. Means
yes, madam.
Take dorsalis pedis. So so diabetic patients need that. Thank you, madam. Thank you for your patience.
Thank you, madam. Thank you, madam. Yes. Mr. Deepen, sir. Mr. Deepen, sir.
Yes, madam.
Yes, all the webinar is just over. So you can just, log out.
Okay, sure.